So, good morning, everybody. I welcome you all for the day 2 of this academic bonanza. And without much ado, I will invite none other than Dr. Rajiv Sareen. Dr. Rajiv Sareen doesn't require an introduction to all over our country and to give the welcome address and start this academic bonanza today. Dr. Rajiv Sareen, over to you, sir.
Thank you, Dr. Walia, for inviting me and the team, your entire team, Gagan and others, Tabassum, Rima. This is a very important session. And as I was hearing that yesterday's day 1 was also excellent participation. So there are a lot of new things that are happening in breast cancer. As far as radiotherapy for breast cancer is concerned, it is not just fractionation. So today, there is no stage of breast cancer. There is stage 0, stage 1, 2, 3, 4, where breast cancer is not an integral part of the multidisciplinary management. And to make things more exciting, we know that it was always there in palliation, in stage 4 breast cancer, but also for prevention, there are studies going on where that can prevent breast cancer in those who have a BRCA mutation or definitive treatment. So trials are going on. So the entire spectrum of disease and in various clinical contexts, radiotherapy is being used. And there's a lot of new data which is coming up. And the issue with breast cancer is you have to wait for many years for the data to mature and where you can have a take-home message and you can go back and tell your patients confidently. But the studies that have been chosen and the discussions are such that you will see that a lot of practice points as well as the nuances would be discussed, and all of us can apply our mind. I think the discussions as they happen would allow us to crystallize some thoughts and see what is there for our patients that we can apply and what is there based on which we can do more research. So thank you very much. And I will now request the organizers to take it forward. I would like to thank the scientific committee and the program committee for really picking up the right thing. I was just a spectator. I was just watching it from the side. I didn't have to do anything. I didn't have to suggest anything. So thank you very much. All the best.
So thank you, Dr. Rajiv. That has been very encouraging. And now I will invite our chairpersons for the first session, Dr. Punita Lal, a very senior radiation oncologist from Lucknow, and Dr. Monish Goyrala, and kindly to start the session 1 today and invite the speakers for the same. Dr. Punita Lal, over to you, ma'am, and Dr. Monish.
Thank you, Dr. Meenu. Good morning, everybody, and thank you for giving us this opportunity to be present here in this feast on breast cancer that we are going to listen today. So without any further ado, we will go on to the first speaker, Dr. Sweety Gupta, who's an associate professor, Department of Radiation Oncology, AIIMS Rishikesh. We invite her to talk on the Cyanotype One multicentric randomized trial. Dr. Sweety, please.
Good morning, all. My slides are visible.
Yes, ma'am. Slides are visible.
Hello, organizing committee, to giving me this opportunity. Hello.
Yes, Dr. Sweety, your slide is visible and you are audible too.
Yeah, thank you. So preservation, my topic of presentation is preservation of axillary lymph nodes compared to complete dissection in T1, T2 breast cancer patients presenting with 1 to 2 metastatic sentinel lymph nodes, a multi-center randomized clinical trial, the Cyanotype One, with the chief PI being Damino Gentile. So at the background, axillary lymph node dissection has always been a part of the breast cancer treatment. However, the management of axilla has shifted towards a more conservative sentinel lymph node biopsy has now replaced axillary lymph node dissection in node-negative breast cancer axillary staging. The complete axillary dissection may now be considered over treatment for early breast cancer stages, and the recommendation is being challenged because some of the following considerations that the diagnosis tends to be earlier by screening mammography, less than 50% of the patients with sentinel lymph node metastasis usually present with additional metastasis, and the majority of the sentinel lymph node positive patients not undergoing axillary nodal dissection will either receive chemotherapy or endocrine treatment as a part of the management. So axillary lymph node dissection remains the standard surgical technique when the sentinel lymph node is macrometastatic. So the American College of Surgeons Oncology group, the Z0011 trial, they questioned the therapeutic benefit of axillary lymph node dissection in patients who had metastatic sentinel lymph node. Patients undergoing breast cancer surgery, conservative surgery, and whole breast radiotherapy with 1 to 2 metastatic sentinel lymph nodes were randomized either to axillary nodal dissection or no further axillary treatment. But the trial concluded that axillary dissection did not provide any outcome advantages. But this trial had some controversial issues and limitations due to there was the premature enrollment of conclusions. There were too many patients, more than 20% were lost to follow-up. Half the patients presented with micrometastasis, and there was lack of radiation quality assurance with missing data for more than 2/3 of the randomized patients. So the rationale for this Cyanotype 1 trial, the majority of the limitations of the Z0011 trial seriously confounded the interpretation of the final results, being impossible to extrapolate and generalize the findings beyond the low-risk study population. So the breast unit of the Humanitas Clinical Research Center, the Milan, Italy, they promoted the multicentric clinical trial, the Cyanotype 1. So what does the Cyanotype Trial 1 is? It's a prospective, non-inferiority, multicentric randomized study which aims at assessing the therapeutic role of axillary lymph node dissection in patients who are undergoing either breast conservative surgery or mastectomy for T1, T2 breast cancer, presenting with 1 to 2 macrometastatic sentinel lymph nodes. So 52 different Italian centers have been participating. The enrollment has completed in April 2020, with the follow-up is ongoing. So the study design, the inclusion criteria was they have taken age more than 40, less than 75, invasive breast carcinoma, ET2, and clinically node negative axillary. There should be no more than 2 sentinel lymph nodes with a proven metastasis, and the macrometastasis should be more than 2 millimeter. There should be no distant metastasis, no neoadjuvant chemotherapy or neoadjuvant hormonal therapy. There should be no previous history of invasive carcinoma. Patient should have given a written informed consent. Whereas the exclusion being the pregnancy, breastfeeding, inflammatory breast cancer, in situ breast cancer, synchronous contralateral breast cancer, the comorbidities which prevent giving adjuvant therapy to the patients, disease or comorbidities which might be preventing her compliance to a regular follow-up, or there was a previous history of neoplasm except the carcinoma in situ. So the randomization was done in a standard arm, which included the axillary lymph node dissection plus adjuvant therapy, whereas the experimental arm, there was no axillary treatment, but adjuvant therapy alone. So the primary endpoints are the overall survival, whereas the secondary being the loco-regional recurrence-free survival and distant disease-free survival. So the results have been interpreted, which have been that they have included randomized till now 889 patients. There were 443 in the standard and 446, but 4 were excluded in the standard arm. So finally, there were 439, the intention to treat population, whereas 440 in the experimental, 6 being excluded. More than 75% of the patients in both the arms included the breast conservative surgery, whereas the mastectomy included 22 and 23%. The mean sentinel lymph node excised were 1.96 with a median of 2 in both the arms. There were 341 patients with 1 sentinel node in the standard arm and 2 in 96 patients, whereas 326 patients and 110 with 1 and 2 respectively in the experimental arm. The micrometastasis was present in 2 patients in standard and 3 in the experimental. The 417 patients had undergone axillary dissection in the standard arm, whereas there was a deviation in the protocol in the 22 patients, and also the positive non-sentinel lymph nodes have been excised. There were 193 cases with a mean of 1.24 nodes and the median positive sentinel nodes being 0 to 22, whereas none of the 13 patients had undergone a deviation and had undergone axillary dissection in the experimental arm. So the follow-up events, there were 16 events in the standard and 20 in the experimental arm. There were 4 mortality in both the cases, both the arms, with 1 axillary recurrence in both the arms. There were 0 ipsilateral breast recurrence in the standard and 3 in the experimental arm, 7 distant recurrence and 8 in the experimental arm. Second primary tumors were 5 in standard and 6 in experimental arm. Follow-up, the median has been 33.3 in the standard and 34.5 in the experimental arm. But none of the results have been statistically significant difference in terms of survival and recurrence in the 2 different groups of treatment. So they have compared the timing of axillary recurrence, and they have found that when compared to the previous studies, the median follow-up of the Cyanoderm one arm as concerned to the median axillary relapse-free time has already crossed, and they have a follow-up of more than 34 months. So there have been 4 major trials, which non-inferiority trials, which are comparing the axillary dissection with versus no axillary treatment in early breast cancer, which might answer this question: Z011, Cyanodar 1, the POSNOC, and the Insomnia. The main differences between the 4 trials are between the age recruitment, with the Cyanodar 1 more than 40, less than 75, whereas the Z011 and the POSNOC have included more than 18, and Insomnia more than 35. Secondly, they are varying in the surgery type. The Z011 and the Insomnia have included only the breast conservative surgery arms, whereas the Cyanodar 1 and the POSNOC both are including the breast conservative surgery and mastectomy patients. So to conclude, though, there has been an overlap between the results of Cyanodar 1 trial and those of the Z011, and these are very convincing. The Breast Unit of the Humanitas Clinical and Research Study believes that the condition of uncertainty that justified the randomization between complete axillary dissection and omission now no longer exists. And they also expressed a favorable opinion on the proposal to include omission of complete axillary dissection in the internal guidelines. Now, the takeaway and the Indian perspective on this trial, the Cyanodar 1 is expected to provide more robust evidence on the safety of LND omission in well-defined and possibly larger population of patients with limited sentinel lymph node macrometastatic disease. So, our perspective in an Indian scenario, the Cyanodar trial has included an age group of more than 40 and less than 75. But the proposal should be that we should also include the patients who are more than 18 years of age group, because they have some aggressive histology. So 18 and 39 should also be addressed. They have included more than 75% of the breast cancer conservative surgery, but a major chunk of the population should also include the mastectomy, where we can avoid the post-mastectomy radiation as well. Adjuvant therapy, Cyanodar 1 had included whole breast irradiation with BCS only, whereas in Indian perspective, as we get more of mastectomy patients, we should include whole breast irradiation for BCS and PMRT only if indicated, and there should be a subgroup analysis how they fare in the long follow-up. Quality assurance has not been mentioned in the Cyanodar 1 trial, but in Indian perspective, yes, we should include that part also. Secondary endpoint, they have included the loco-regional recurrence-free survival and the distant disease-free survival. The quality of life parameter is a very important parameter which needs to be assessed, and we propose this for an Indian perspective. And also a subgroup analysis of factors such as age, grade, receptor status, and LVCI, which may be associated with a higher risk of axillary recurrence. Thank you.
Thank you. From the audience? If there are none, I mean, I would just like to say, yes, this is a sequel or a consequence following the trials which have talked about axillary treatment or not. The ones that were all, like you have rightfully pointed out, they were unable to answer the question that the disease with lymph node negative disease, which turns out to be sentinel lymph node positive, whether or not we should treat the axilla subsequently. And that's a very important question which we will look forward to. And the Indian perspective that you have given, especially dealing with, you know, not being so selective regarding the age, and most importantly, I think the QA of radiation, which is what we really need to standardize and work upon. So thank you. Any comments, Dr. Rajiv?
Yeah. See, when you talk of sentinel node, so how many Indian centers have validated their procedure for sentinel node biopsy and they have presented the results on a large enough patient? So I think you have to keep in mind this is in a trial setting where the procedure of sentinel node biopsy, and this has happened almost 10 years after sentinel node biopsy, the concept was introduced in the West. And who's looking at the pathology and, you know, whether the whole procedure of sentinel node biopsy has been validated in that center.
I fully agree with you on that. It really needs a proper surgeon's input in that. But as we are going along, we are finding has been looked into, and Dr. Rashi will talk about the Pathways Heart study. Dr. Rashi, please.
Yeah, thank you so much, organizers, for giving this opportunity. And thank you so much, Punita ma'am, for introducing me. So I am going to present the abstract of the Pathways Heart study. As Dr. Punita has already mentioned, yes, we all are worried about this. Many breast cancer therapies routinely that we use that are cardiotoxic. And we also know overweight and obesity, they are also risk factors for cardiovascular disease. So the question arises, does the risk of cardiovascular disease varies by BMI in our patients, in our breast cancer patients? To address this question, this study was started, and the patients were chosen from KPNC, California region. And in this study, breast cancer patients who were diagnosed between 2005 to 2013, they were included in the study. And these patients received chemotherapy in the form of anthracycline, trastuzumab, taxane, cyclophosphamide. They also received endocrine therapy and also received radiation therapy, either right side, left side, either side. And the outcomes that were observed were ischemic disease, heart failure or cardiomyopathy, or stroke. And Cox proportional hazard model was used for statistical analysis, and the woman whose BMI was less were 13,582 with mean age of 60 years and with mean follow-up of 7 years. So coming over the results regarding heart disease, so the results were actually, I was very much surprised to see all these results. So for women with normal weight, so the who were receiving anthracycline, they were at higher risk of developing ischemic, as you can that's only 2 minutes because this study. So this the another important point that I want to show you, that incidental heart failure and cardiomyopathy for women with normal weight, they were more common with the patients who were receiving anthracycline, cyclophosphamide, or left-sided radiation therapy. But for obese women, there were not factors. There was no risk for obese women. This was very, that we think it's very different from what we think. And when we talk about stroke, so stroke was you can see in this forest graph, was less for the patient who were obese but who were receiving anthracycline, who were receiving taxanes or cyclophosphamide. And for when we talk about normal weight, for a normal weight women, the patients who were receiving taxanes, cyclophosphamide, or left-sided radiation, they were having higher risk in comparison to the women who were not receiving these therapies. So to conclude, certain chemotherapy drugs and left-sided radiation may confer high risk for breast cancer survivors with normal weight. Yet, yes, what they have observed, certain drugs may lower stroke risk for breast cancer survivor patients with obesity. So this was actually different. I think it's a very difficult to say what about this. So they have concluded it may be due to obesity paradox that has been observed in other population also. So when I talk about Indian perspective, so what I think, I have seen so many studies, but we should actually do from because Indian patients are different from these patients. We are having now more patients are having cardiovascular disease. So we should start these type of studies, and the results of this study is actually very different. So they what they do, they have analyzed, they have planned that they should examine what they should see what different doses and duration of other therapies across the BMI groups have contributed to these risks. Thank you so much.
Thank you so much, Dr. Rashi, for an interesting presentation. We shall be taking all the questions in the end and in the panel discussion. So that was very interesting, and we hope to have some discussion on that. We now move on to the next speaker, that is Dr. Akshay Mangaj. He's a consultant in Department of Radiation Oncology in MPCT Hospital, Mumbai, and he shall be talking about the Lumina trial in endocrine therapy of the breast cancers. So Dr. Akshay, please.
Thank you for the introduction. Am I audible now?
Yes, sir, you are audible.
Okay. So I'll be talking about the study Avoidance of Radiotherapy for Low-Risk Early Breast Cancer using Lumina trial criteria and accounting for endocrine therapy adherence. So adjuvant radiotherapy is a standard component for breast conservative therapy for early stage breast cancer. EP-CTCG meta-analysis has shown that radiation therapy halves the 10-year rate of any breast cancer recurrence with an absolute reduction of 15.7% and reduces the 15 years breast cancer mortality rate by about 1/6 with an absolute reduction of 3.8%. After radiation therapy, the 10-year gain in radiation recurrence is more in node positive as compared to node negative breast cancer patients. However, radiotherapy is not without risk, and some patients at very low risk of relapse, the risk of radiotherapy may outweigh the benefit, leading to potential overtreatment. Randomized controlled trial have shown that omission of radiotherapy in low risk breast cancer does not reduce overall survival or increase breast cancer mortality, and the breast cancer recurrences are salvageable. As you can see, there are multiple studies in which, although the local recurrence rate are higher, but those are salvageable and there is no difference in overall survival. However, it did not change the practice due to concerns, mainly that the lesser duration of follow-up was there in this trial to identify the late recurrences. Lack of information regarding histology, grade, margin status, or presence of lymphovascular invasion was taken into consideration while design of the trial. And clinicians feared that endocrine therapy compliance could be less rigorous outside the setting of a clinical trial. In modern era, there are tumor subtypings assessed through immunohistochemistry, genomic expression, or signature assays is a promising strategy to identify subgroup of low-risk women whom we can whom adjuvant RT can be spared after breast conservative surgery. There are different clinical studies presently going on, which are using biomarker-based trial, like Lumina trial, IDEA, Precision, Prime trial, Expert, which are using various selection tests, and they are omitting radiation in these trials. This study is a retrospective study in which they have identified women with pathological T1, T2, and breast cancer treated with conservative surgery between 2000 The inclusion criteria from the luminal trial were used to select very low risk population, and subgroup analysis was performed to investigate the influence of endocrine therapy adherence to an outcome. They reported a treatment outcome with low risk ER positive early stage breast cancer treated with adjuvant RT or RT omission. Data collected include demographic features, tumor characteristic, treatment type, endocrine therapy adherence, and local regional recurrence events. To identify the middle trial were applied, such as age more than or equal to 55, unifocal unilateral tumor with ductal, tubular, or mucinous histology, T1, N0, grade 1, grade 2 tumors, ER, PR positive and HER2 negative, LVI absent, cut margin more than 2 mm, KI 67 less than or equal to 13.25, and patients agreeing to start endocrine therapy. 5-year local regional control rates were compared across group using the Kaplan-Meier method. 110 patients met Lumina inclusion criteria, of which 82 were treated with EPRT and RT was omitted in 28 patients. Endocrine therapy adherence information was available for 96 patients. In this study, patients who completed 5 years of endocrine therapy or discontinued owing to disease recurrence or death were categorized as endocrine therapy adherent, and those who discontinued before 5 years due to other reasons were categorized as endocrine therapy non-adherent. This table shows patient tumor and treatment characteristic. The median age in the RT group was 63 and in the RT omission group was 73 years. Majority were ductal histology. Endocrine therapy median duration in RT group was 60 months and in non-RT omission group it was 55 months. Results showed that the median endocrine therapy duration in endocrine therapy adherent group was 60 months as compared to non-adherent group it was 19 months. 5-year local control rate for RT was 100% as compared to 94% in the RT omission group, which was significant. On subset analysis, 5-year local regional rates for RT and RT omission were both 100%, and in patients who were not adherent to the endocrine therapy, the local control rate was 100% in the RT group and 83% in the non-RT group. So they concluded that patient with low risk early stage breast cancer selected using criteria from the Lumina trial exhibited excellent local control with endocrine therapy alone if they were treatment adherent. This finding awaits validation in large prospective cohort study. However, ET alone may be insufficient in patients likely to be non-adherent to the treatment, and notably, prospective trials should closely follow up and report ET adherence. So take-home message is that the main challenge is to identify the most suitable subset of early breast cancer patient who will benefit from avoidance of RT. Large prospective studies are needed for the same. Perhaps comprehensive integration of features such as patient's age, comorbid condition, life expectancy, and tumor-related factors, including the classical factors like size, hormonal receptor status, grade differentiation, and genetic and molecular features may enhance our ability to properly identify patients at low risk of recurrence. Composite endpoints evaluating not only the tumor recurrence rate and OS, but also toxicity, patient's quality of life, psychosocial issue, and cost effectiveness needs to be included to better tailor the clinical decision-making process in low-risk early-stage breast cancer. And patient and clinicians' perceptions regarding the apparent benefit of treatment in specific group of patients needs to be challenged, and the concept of avoidance of treatment to prevent over-treatment needs to be introduced. These are the references. Thank you.
Thank you, Dr. Akshay. Very well put. And as you rightfully said, to identify this group, you will need a very large prospective trial to be conducted to be able to actually say with confidence. Thank you. So we move on to the next speaker, that is Dr. Seerat Puri. We invite her. She's a consultant in Department of Radiation Oncology, Mulanpur TMC, and she will be talking about the APBI in re-irradiation setting. Dr. Seerat, please.
Hello. Mm, am I audible?
Yes, you are.
Yes. Good morning, everyone. Thanks for giving me this opportunity. I'll be presenting a multicentric prospective study by Espinosa Bravo et al. From Val d'Hebron Hospital on safety of conservative surgery with accelerated partial breast re-irradiation for isolated ipsilateral breast cancer recurrences, regardless of the immunohistochemical subtype. So as we know that breast cancer surgery followed by whole breast irradiation yields excellent in-breast control rates and is recognized as standard local treatment for properly selected early breast cancer patients. And the long-term follow-up suggests that there is a ipsilateral breast tumor recurrence rates of approximately 10% in these patients, for which mastectomy is the acknowledged treatment of choice. As it concerns over the cosmesis after the new lumpectomy and also concerns the complications related to the previous radiation toxicities. So that is why salvage mastectomy is the treatment of choice here. But when we see the results of salvage mastectomy, the chest wall failure rates are around 15%. The range is 3 to 32%. And also, if we try to conserve the breast, so the in-breast re-recurrence rates after repeat lumpectomy alone were also high, ranging from 19 to 50%. So definitely there was a need for additional modality here, for which whole breast irradiation will not be answered because of the excessive toxicities to the organs at risk like lung, heart, and subcutaneous skin tissue. So therefore, there is a potential to explore the option of accelerated partial breast re-irradiation in order to achieve the acceptable OAR doses. So what they did in 2014 to 2020 from 3 university hospitals in Barcelona, they have selected 35 patients and prospectively followed them after a new lumpectomy and accelerated partial breast re-irradiation was offered. So the patients were selected. The age was more than 50 years, more than 48 months from the local primary treatment. Tumor size less than 2 centimeters. It should be isolated IBTR, no nodes present, no multicentric or multifocal tumor in MRI, no major previous radiation-related toxicities should be there, and breast volume to excision ratio should be favorable for cosmesis. Endpoints were second IBTR rate, 5-year regional free survival, metastatic free survival, and overall survival. So what they saw that out of total 35 patients, the median age was 65 years. Median time to IBTR was 154 months. The most of the patients, 77% of the tumors showed invasive component, and 51% of them were moderately differentiated. Out of the locations, 48.6% had recurrence in the same quadrant, 45.7% had in the different quadrant. Majority of the patients had estrogen receptor positivity, 45% had progesterone receptor positive, and only 70% overexpressed HER2 positive. So according to the subtypes, 33% were luminal A, 40% were luminal B, and only 17% were HER2 positive tumors. So what they did after lumpectomy, they had offered APBI in 3 techniques. 67% were given IMRT, and 27% with 3D CRT, and 6% with intraoperative radiotherapy. All the patients who were ER positive were given adjuvant endocrine therapy, and all the patients who were TNBC and HER2 positive, they were offered chemotherapy, and targeted therapy was given to all the HER2 positive patients. So on the follow-up of median follow-up of 37 months, there were 4 relapses reported. Only one was second IBTR, which followed in situ IBTR, and rest of the 3 were metastatic. It was seen that both the metastatic progressions after the invasive IBTR were ER/PR positive and HER2 negative. Looking at the oncological outcomes, second IBTR rate was 2.85%, 5-year regional free survival was 82.4%, metastasis free survival was 85%, and overall survival was 93.3%. looking into the literature, there is no phase 3 trial till date regarding salvage mastectomy versus breast conservation therapy. Although the published previous literatures, they have proved that second recurrence after salvage mastectomy is comparable to the results with the second breast conservation therapy. This is from the literature from Jack Castro Breast Cancer Working Group. This states that in 217 patients, when salvage mastectomy was compared with accelerated partial breast irradiation with interstitial brachytherapy, the second IBTR actuarial rate at 5 years was 5.6%. And also similar rates were seen, oncological outcomes were seen in this paper also. 5-year overall survival was 88.7%, and excellent cosmetic outcomes to 85% were seen. To our knowledge, this is the largest propensity score matched cohort analysis in this subject, which is from the Jack Castro group, where 1,327 patients were included. And after a median follow-up of around 75 months, it was seen that there was no difference in 5-year overall survival when salvage mastectomy was compared with second conservative treatment, 88 versus 87%, and no difference in cumulative incidence for third event were seen. And 5-year cumulative incidence of mastectomy was 3.1%. So far from these papers, we can see the oncological outcomes are almost comparable, but in the present paper, they have mentioned regardless of the immunohistochemical status, but the HER2 positive, which generally do worse, they are only 17%. So we cannot come to a conclusion from this paper regarding the prognosis from the immunohistochemical status. Now, regarding the toxicity from radiation, this is a paper by NRG, RTOG 1014, where 1-year toxicity was reported by after repeat breast preserving surgery along with 3D CRT accelerated partial breast irradiation, where it was seen that treatment-related skin fibrosis or breast pain adverse events were within the acceptable limits. So in terms of toxicity profile also, we can offer re-radiation, accelerated partial. So from this paper, we conclude that conservative treatment with BCS and APBRI for isolated breast tumor recurrences after BCS seems like a feasible technique as an alternative to mastectomy in selected cases. So there should be, to mandate this, the phase 3 trials should be conducted. So the choice remains between two salvage treatments should be totally on the basis of the tumor profile, the cosmesis, and the cutaneous and subcutaneous consequences of the first radiotherapy. Since the local rates from the previous discussion states they are similar, it seems like a feasible technique. And finally, the patient's choice matter. Thank you.
Thank you, Dr. Seerath. So, yes, it seems to hold some promise for the future. Let us see. And maybe in select situation, like you said, very rightfully mentioned. Unfortunately, there are several burning questions, but we won't be able to take because we are running short of time. I now invite my co-chairperson, Dr. Manish Gairola, to take over from the next talks.
Good morning, everybody. Again, thank you, Dr. Punita. Just to carry forward the session, next talk in this session is Dr. D.N. Sharma, is Professor Head, Department of Radiation Oncology at All India Institute of Medical Sciences and AIIMS Jhajjar. And he will be talking on the loco-regional treatment, de-escalation of breast cancer radiotherapy. Professor Sharma, please. Before he is putting up the slides, I would like to again mention here that I got strict instructions from Dr. Gagan Saini that we should complete, since we are running late and time is a constraint, so we should complete all the topics on time. So, Dr. D.N. Sharma, please.
Thank you, Manish, for reminding that.
No, I know. You will do everything.
Respected chairpersons, ladies and gentlemen, very good morning. Thank you, Gagan and your team, for inviting me and giving me this talk. Now, I am supposed to discuss the de-escalation of breast radiotherapy based on the presentation made by the Dr. Bradley from University of Florida. This was presented in the spotlight session in the poster discussion during the San Antonio Breast Cancer Symposium 2021. And I will extend the discussion based on these two posters which were presented in the San Antonio. And these two studies have been already presented by the previous speakers, Dr. Seerath and Dr. Rasi. So I'll be very brief because they have been most of the points have been already covered. To begin with, there are certain biomarker based trials going on to omit the role of radiation treatment in the early stage breast cancer. Although my speculation is that probably it will be not possible to replace the role of radiation treatment in the early breast cancer. Maybe a select group of patients can be omitted, like elderly breast cancer with ERPR positive and HER2 negative. But otherwise, it seems difficult to replace the role of radiation in the early breast cancer management. This is another DEBRA trial, which is NRG 007. The target accrual is 1670, and it is open for accrual, but there are many breast cancer radiotherapy regimes in this trial, but we will eagerly await the results of this trial for the role of the radiation in the early breast cancer regarding some of the criteria for omitting the radiation treatment. Now, this was the poster which was presented in the San Antonio, and it was previously discussed by one of the speakers. And as you can see, there are the clean group of patients where the risk of recurrence is very low based on the clinical and the biomarker parameters. And I will not go in details, but if you see the conclusions of this trial, that the patients with the very low risk of early breast cancer recurrence based on the Lumina trial criteria, if the patients are adherent to the hormone treatment, then the results are very good. The local control is very, very good. But at the same time, if the patients are not adherent to the hormone treatment, and if you omit radiation treatment, then the results are inferior. So therefore, it is a note of caution that we need not omit radiation treatment at the upfront, because when you decide what the role of the adjuvant radiation treatment, it's not easy to decide whether these patients will be adherent or non-adherent. So, and especially in Indian context, I think so it will be very difficult to categorize whether the patients will be adherent or non-adherent. So I think we must encourage the role of radiation even for luminal criteria patients. Now, why do we discuss so much about the adherence to endocrine therapy? And this is one study which was published in JAMA Oncology last year, and where they found that at the end of 4 years, the 11% patients did not continue the hormone treatment based on certain factors. Another study, which although a bit old, published about a decade back, and it was found that about 50% of the patients did not continue the prescribed hormone treatment in terms of duration as well as the schedule. So therefore, the adherence to endocrine treatment has been a problem even for last 10-15 years. And patients who are at younger age and patients who are Black, who do not have the insurance coverage, they are likely to discontinue the hormone treatment as compared to the other patients. Now, the second poster which was presented in the San Antonio regarding the omission of the radiation treatment, and if the mastectomy alone can be the answer. As Dr. Seerath already told, the 10-year local failure rate after BCT is about 10%, 5 to 10%. And as of now, the standard care is the mastectomy. But the re-BCT, including the re-APBI, is being tried in many trials. And I am fully aware of the outcome of these patients. And I am already on the same note, I'm doing some of the patients who come to us, although very select patients we take for re-APBI after the ipsilateral breast tumor recurrence. So these were the results of this trial. I will not go into details because they were already covered. And but these are some of the trials which are already published, showing the local recurrence after the salvage lumpectomy alone. And if you see the recurrence, it is about it ranges from 4 to 32%. So if you do only lumpectomy, the recurrence is high. And this is very nicely summarized in the review article published by Dr. Tabassum from Tata Memorial in Clinical Breast Cancer 2017. And if you see the Salvage mastectomy series without the any adjuvant treatment, and even in these series, the recurrence rate, chest wall recurrence at 5 years is about 15%. Again, is not acceptable. And if you see the series showing, trying the salvage lumpectomy plus the partial breast re-radiation, and if you see here, the results are very good. At 10 years, the local re-recurrence is about 7%. And in some of the trials, this 5-year also is as high as 100%. So if you combine the salvage lumpectomy plus the partial breast re-radiation, the local control is fairly good. And if you see the, I don't know whether you can see the toxicity is about grade 3, grade 4 is almost like insignificant, and it is well within the acceptable limits. Another is the Jack Astro Breast Cancer Working Group database showing the cumulative incidence of third episode recurrence, and the incidence of the regional recurrence is more or less same. The p-value is not significant across the two group of patients. That means the mastectomy and the lumpectomy plus the re-radiation. Even the distant medicine disease-free survival is more or less same. So if you do the lumpectomy plus the re-radiation, it is as good as the local mastectomy. This is the comparison of the two the trials, the NRG 1014. RTOG 1014 and the Spanish trial, which was just presented. And if you see the bottom line is 5-year overall survival is like 93% and 95% in the two trials, which is fairly good. Italian recommendation for selecting the patients for lumpectomy plus the re-radiation, that means the re-BCT, age more than 50 years, smaller tumor size like less than 2 centimeters, DFI more than 4 years, and absence of any multifocality, multicentricity, or the patient's urge to conserve the breast, and the acceptance for the cosmetic results. This is just the summary and the take-home message of the two trials. Regarding the omission of radiation for early breast cancer patients based on the Lumina 8 trial, I think it is in Indian context, I would say it is not possible to omit radiation therapy in any of the EBC patients because the follow-up is not really good. The adherence to hormone treatment is also questionable based on the economic factors and the other factors. As for the second take-home message regarding the re-BCT with re-APBI, I think it looks feasible. And although in such a short time we could not cover many studies, but it looks like that the IBTR is about 3% at 3 years, and 5-year oral surveys are like 93%, which seems fairly good. Therefore, I would say that from my side that the for re-BCT, partial breast irradiation is fairly good option from the radiation point of view. Thank you very much.
Thank you, Dr. Sharma, for completing the talk on time. I know a lot of questions, comments, and queries and concerns, they are there. But again, in view of less time, and so I would switch over to another topic of this session. This is Dr. Shagun Mishra. She is Associate Professor Radiation Oncology at SGPGI Lucknow. And she'll be talking about the can radiation replace ALND after positive sentinel lymph node biopsy. Dr. Shagun, please. Dr. Shagun, are you on mute?
Okay, I am.
Yeah, sorry, I was unmuting myself. At the outset, I would really like to thank the chairpersons and the organizers for inviting me, and it's a pleasure to meet our mentors and our colleagues this way. So without wasting much time, I would be dwelling on my talk basically, which was presented by Dr. Jaxi, looking into whether axillary radiotherapy can replace axillary lymph node dissection following a positive.
sentinel lymph node biopsy. All of us know that the motivation to seek an alternative to axillary radiation, axillary lymph node dissection, is the toxicity caused by such a procedure. And there has been an impetus amongst the surgical as well as the radiation colleagues to look for alternative
Ma'am,
measurements.
sorry to interrupt. Kindly, please make it the full screen.
It's already full screen on my
No,
laptop.
it's not.
So what you are sharing is, yeah.
Is it full screen?
It's not in the slideshow mode. So what you probably are sharing is different.
Please. So I'm sorry for that interruption with these kind of goof ups. So the motivation to seek an alternative to axillary lymph node dissection is no. We know the toxicity caused by dissection procedure, and there is motivation amongst the surgical as well as the radiation colleagues to look for options wherein the toxicity is decreased, and this does not compromise the local control rates. Can we go on to the next slide, please? Historical studies which basically gave us some guidance in terms of de-escalating therapies to the axilla can be dwelt upon. And one of the studies which was done about 2-3 decades ago, and very important in this regard, is the NACBP04 trial, wherein patients with node negative early stage breast cancer were randomized to radical mastectomy versus total mastectomy with regional nodal radiation versus total mastectomy followed by axillary surgery if there was a recurrence that was noted. And what this trial showed was that the regional recurrence were not different between the radical mastectomy versus the total mastectomy and the regional nodal radiation arms. And more importantly, this trial showed that the lymphedema rates were significantly lower with axillary radiotherapy as compared to that of axillary surgery. A substantial number of patients who underwent a completion axillary lymph node dissection did have positive lymph nodes in the axilla to the tune of about 30-35%. Yet this did not translate into increase in the axillary recurrence rates, provided they were giving radiation. And the thought process that is prevalent amongst the oncologists is basically that axillary lymph node dissection as a procedure in early stage node negative breast cancer is used to guide adjuvant systemic therapy decisions, and which can very well be replaced now by a sentinel lymph node biopsy. Next slide, please. The surgical committee moved forward in terms of de-escalating treatment to the axilla by adopting the sentinel lymph node biopsy procedure, and this is one of the standard of care, at least for a clinically node negative early stage breast cancer. And the radiation oncology community trying to back up the surgical colleagues by trying to look into the fact that whether radiation can obviate the need of a complete axillary lymph node dissection in patients who have limited disease in the axilla identified by a positive sentinel lymph node biopsy. And there were 2 trials which were conducted about 2 decades ago in this regard, and I'll be dwelling on both these trials one by one. Let's go to the next slide. Next slide. So the first trial was conducted by the European group, and here in patients with a T size less than 5 centimeters, node negative early breast cancer, patients were randomized to axillary lymph node dissection versus axillary radiotherapy. And this randomization was done before the sentinel lymph node biopsy. And following this, they underwent a sentinel lymph node biopsy. Those who were found to have a positive sentinel lymph node were further randomized to receive axillary radiotherapy versus axillary dissection, depending upon the arm in which they were randomized. And the randomization was done before the sentinel lymph node biopsy in order to remove the bias, the allocation bias. This was a non-inferiority trial design, and with axillary dissection, the rates of local axillary recurrence were thought to be 2%, and with radiation, the assumption was the non-inferiority would be established if the rates were no more than 4%. Let's go to the next slide. So this is a consort diagram wherein 4,800 patients were randomized. About 2,400 patients underwent in each arm underwent the axillary sentinel lymph node biopsy procedure, and those who were positive, that is 700 nearly in each arms, were subjected to dissection or axillary radiation. And the event rate with the axillary dissection was assumed to be about 2%, but the event rate was very low, and the Independent Data and Monitoring Committee then approved of going ahead with the analysis, although the primary endpoint for inferiority was certainly underpowered. Just to go into the inclusions of these patients, most of the patients, 60 patients, were postmenopausal. The median age was 56 years. Majority of the patients had undergone BCS with a median T size of 1.8 centimeters. Non-sentinel lymph nodes. Next slide, please. So the 5-year results of this trial clearly demonstrated that there was no difference in the axillary recurrence rate, the disease-free survival, or the overall survival. Importantly, this trial demonstrated that the lymphedema, as assessed by clinical observation, was halved with axillary radiotherapy as compared to that of dissection, and this was substantiated further by the objective measurements in arm circumference, suggested that certainly axillary radiation does decrease the lymphedema rates. The median number of sentinel lymph nodes that were removed in both the arms was 2. And 60% of the patients had macrometastases, and more than 4 nodes positive in the axillary lymph node dissection arm was seen in 8% of the patients. Next slide, please. The update of the trial presented in 2018 showed that the axillary recurrence rates were no different between the arms of axillary radiotherapy versus axillary surgery, but the lymphedema rates as seen by clinical observation or by treatment was significantly lower with axillary radiation at 1 year. Next slide. The range of arm movements were also not very significantly different between both the arms, except for the fact that at 1 year, the range of arm movements were numerically worse in the axillary radiation arm, but statistically, this difference was not significant. Next slide, please. The second trial was the Otasaur trial. This is a Hungarian trial wherein the trial design was very similar, except for the fact that the randomization between the dissection versus radiation was done after the sentinel lymph node biopsy procedure. And this trial again looked into patients with a T size of less than 3 centimeters, node negative, clinically node negative breast cancers who were deemed positive on a sentinel lymph node biopsy. Next slide. And randomization was between completion axillary dissection versus radiation alone. And this trial, at a median follow-up of 8 years, demonstrated that there was no difference in the axillary recurrence rates, and there was no difference in the overall or the disease-free survival. It was interesting to see that in the axillary lymph node dissection arm, about more than a third of the patients did have residual positive non-sentinel lymph nodes, and 22% of the patients had 4 or more positive lymph nodes. And these patients were further subjected to axillary radiotherapy as well. Next slide. This trial also showed that the toxicity of the radiation procedure as compared to completion dissection was certainly less at 1 year, and combination of dissection plus radiation certainly increased the morbidity. About a third of patients did have significant lymphedema, although this differences in the arm symptoms did not translate into differences in quality of life outcomes. Next slide, please. So summary of these two trials suggests that axillary radiotherapy certainly can be a reasonable alternative to axillary dissection in patients who, very similar patients who are enrolled in these trials after a positive sentinel lymph node biopsy. That is, patients who are clinically node negative, and most of the patients had 1 to 2 positive sentinel lymph nodes. But these trials do not answer the question as to whether any radiotherapy is required at all following limited disease identification in with the sentinel lymph node biopsy procedure, because there have been trials, that is the Z11 and the International Breast Study Group trial, wherein patients following a positive sentinel lymph node biopsy were subjected to no further treatment, and again versus axillary dissection, and there was no difference in the outcomes. I will not go into the IMN controversy, because that's like opening a Pandora box as to whether even comprehensive regional nodal radiation is required, or is it just sufficient to treat the axillary and the supraclavicular levels following a positive lymph node. Thank you very much for your kind attention.
Thank you, Dr. Shagan, for a very nice and pertinent topic. But again, for the interest of time, we will not take up any questions or comments because we are already late. So for next talk, would like to call upon Dr. Sagar Gayakuad. He is a senior consultant, Department of Radiation Oncology at Asian Institute of Medical Sciences, Mumbai. And he'll be talking about refining axillary management after neoadjuvant chemotherapy. What does the evidence support? Dr. Gayakuad,
someone please put up my slides. Hello?
Yes, sir, we are sharing.
Yeah. Okay. So next slide, please. So I will be presenting talk of Dr. Terry Mamunas about refining axillary management after neoadjuvant chemotherapy. What does the evidence support? Next slide. So basically, this slide is going to be about how safely the axillary lymph node dissection can be minimized in breast cancers. So as we all know that for a longest time in early breast stage cancers, axillary lymph node dissection was supposed to be an undisputed standard of care. But after NSA BP-B04 trial showed that there is no overall survival benefit, and after that its therapeutic role was challenged. Next slide. Next slide. But still there is still rationale for axillary lymph node dissection in early stage breast cancer, considering it still provides a good local control in axilla. It provides a good staging information, and it assists us to get an optimal adjuvant systemic therapy plan. But if you watch closely, the most of all these things can be achieved through sentinel lymph node biopsy also. So, and and at the same time, while it provides us the good information on these topics, at the same time with considerably less morbidity, about which Dr. Shagun has already warned us in last presentation. Next slide. So, can we really decrease the extent of axillary surgery with NSAT in all cases? So right now, as far as the evidence is concerned, feasibility and accuracy of sentinel lymph node biopsy after NAC is still questionable in locally advanced breast cancer. But yes, this concept can be is acceptable in operable and early breast cancers, which is CT3, CT1 to CT3, and clinically node negative to N1 diseases. Next slide. So in this presentation, the flow chart is basically going to be in early breast cancers. Is it feasible to do sentinel lymph node biopsy? Is it feasible and safe to do sentinel lymph node biopsy after NACT in node negative and N1 diseases? Is it safe to omit axillary lymph node dissection in case of all PATH-CR patients who have received NACT? And how to decrease the false negative rates post NACT? And is it safe and can we achieve good local control? And is really the morbidity with sentinel lymph node biopsy is lesser? Next slide. Next slide. So as we all know that post NACT, almost in 30 to 40% cases, the axillary nodal staging is downstage. Next slide. And next slide. And with the extent of better and better chemotherapeutic agents and with better knowledge of tumor biology, we are getting more and more PATH-CR rates, and this is what we want to bank on while considering NACT. And we try to minimize the axillary nodal dissection in early breast cancers. Next case. Next slide. So, but there is still some theoretical concern over applying the sentinel lymph node biopsy concept to patients who have received NACT. There is one anatomical concern that post NACT there might be some alternation in the drainage pathways, and there is a biological concern also that post NACT sometimes the tumor in the sentinel lymph node might regress, but there might be some disease which is left in non-sentinel lymph node. So in either of these situations, there will be a high risk of high sentinel lymph node biopsy false negative rates. So this is the big concern, that we should be sure that there is actually a PATH-CR in axilla when we are getting away with sentinel lymph node biopsy. Next slide. So why it is clinically important to be sure that the axilla is actually actually we have achieved pathologically CR in patients after NACT, because as we know that if you just rely clinical palpation in NACBP B18 trial, we had witnessed that even if the axilla was clinically negative, almost 40-50% patients were node positive when the surgery was done initially, and even after NACT, at least 30% patients were turned out to be a node positive one. So we should be really sure that what we are dealing with. Next slide. So the guidelines do recommend that even if the axilla is clinically, you feel that it's a node negative axilla, the ultrasound of axilla should be done, and it should be augmented with FNAC for the indeterminate node to know its status, and it can be marked in the same setting, which will help us for further nodal removal, and it provides us a good sensitivity and specificity. Next slide. So how we manage the patient with clinically who are CN0, that is node negative axilla, and we are planning to start them with NACT. So should we do sentinel lymph node biopsy in early breast cancer, node negative breast before starting chemotherapy, or it can be done after NACT while we address the breast also? So this question is very important, because if we cannot trust that after NACT the axilla can be addressed, we have to subject patient for surgery twice. But so next slide. But we have a next slide, please. But we have a meta-analysis which says that sentinel lymph node biopsy, if done even after NSAT, has a very low false negative rate, which is somewhere around 6%. And the pooled identification rate for sentinel lymph node biopsy, even after NSAT in such patients, are almost 96%. So it concludes that sentinel lymph node biopsy is technically feasible, accurate for axillary staging in initially clinical node-negative breast cancer patient even after NSAT. Next slide. So what about patients who have clinically hello. So there is another meta-analysis for sentinel lymph node biopsy after NSAT in patients with documented and involved axillary nodes. So the last slide was about the patients who have negative nodes. This slide is for patients who have axillary positive nodes. Here we can see that in this particular meta-analysis, what they found that the after axillary lymph node dissection, the false negative rates were quite high. That was somewhere 13%. And although the identification rate was good, but the conclusion of this meta-analysis was that sentinel lymph node biopsy after NSAT in a biopsy-proven node positive patient results in reasonably acceptable false negative rate and identification rate. So it was making it a valid alternative to axillary lymph node dissection. But there was still a concern that we should improvise the false negative rate and identification rate in such subset of patients. Next slide. Next slide. So these are the four trials. These are the four trials in which the similar thing was done, and different things were tried to get the false negative rates to a lower level. The first trial was the 1071 trial, in which they used the dual tracer, and the false negative rate was somewhere around 12%. The Sentinel trial, in which what they did was they used a technetium dye. It was only a single mapping, and the false negative rate was somewhere around 14.2%. SNF-NSC trial, they again used technetium plus they used the IHC to the sentinel nodes. So in this particular trial, in view of use of IHC, the false negative rate was much lesser than the other trial. It was only 8.4%. And the last Guinea 2 trial, again they used the dual tracer, and with which the false negative rate came down to 11.9%. Another finding which was common in all this trial was whenever the nodal yield was more than 2 lymph nodes, the false negative rate even went down. Like for in Z1071, it went down from 12.6 to 9.1%. In Sentinel, it went down from 14.2 to 7.3% if it was more than 2 nodes. And same about in Genia 2 trial. It again went down from 11.9 to 7.8%. So the conclusion which was from this particular 4 studies was that if we are able to get better sentinel lymph node yield, the false negative rates will go down. Next. So there was again a reanalysis of G1071 trial, in which what they found was that at the time of axillary lymph node dissection, along with the axillary lymph node, if they were able to retrieve the clip also, or the clip node which was initially placed to identify the positive node, the false negative rate went down to 6.8%. So again, from this, they came up with a conclusion that whenever possible, mark the node and try to remove those clip node at the time of axillary dissection. Next slide. Next slide. There is again an MDACC experience in which again they did the same thing. They removed the sentinel lymph nodes also and clip lymph nodes also, and they labeled it as a targeted lymph node dissection, and with which they achieved the false negative rate of 1.4%. Next slide. So there are different methods which are tried in case of a node positive early breast cancer in order to increase the in order to decrease the false negative rate. In this particular trials, RISAS procedure was done, in which what they did in the prior to NSAT, they radioactive iodine was instilled into seeds were instilled into the positive nodes, and they were retrieved at the time of axillary lymph node they were retrieved at the time of sentinel lymph node biopsy along with the sentinel lymph nodes. Next slide. And with this procedure, they were able to get the false negative rate to a 3.47%, and the negative predictive value with this procedure was more than 93%. Next slide. Next slide. Okay. So, the systemic review and pooled analysis gives that if you do a marked lymph node biopsy alone, the false negative rate is somewhere around 6.28%. And if you do a targeted axillary dissection in which you remove both the marked or clipped nodes along with the sentinel lymph node, it goes down to 5.16%. Next slide. So these are the different markers which are commercially available for the marking, and as per the particular institute's guidelines and use, they are getting deployed. That can be steel, titanium, polyglycolic acid, carbon or black ink tattoo, or radioactive iodine or ferromagnetic seeds. Next slide. So these are again newer method radioactive iodine, Savi, Scout, magnetic seeds, which can also be used. Next slide. So I'm coming to almost a conclusion now. So the most important thing for optimizing sentinel lymph node biopsy performance after NACT in documented node positive patient is first appropriate node selection. It is currently applicable only for early breast cancer. Whenever possible, do a dual agent mapping, isotope plus blue dye. Whenever possible, identify and move more than 2 sentinel lymph node. If possible, if a clip placement is done, it should be localized and retrieved. That is what we call as targeted axillary dissection. Consider performing immunohistochemistry staining on sentinel lymph nodes so that we can get the lesser false negative rates. Next slide. So now
Sagar, kindly conclude, please.
Yes, sir. Last 2 slides. So about the axillary recurrence rate with negative sentinel lymph node biopsy alone after NACT, you can see the axillary recurrence rates are almost in a single digit. So it's a relatively safe procedure. Next slide. Then another concern was if there are only micromets in sentinel lymph nodes. In that particular case, if only sentinel lymph node biopsy is enough, or we need to do an axillary lymph node dissection. So as far as the MSKCC experience is, they do recommend that even in the case of micromets, you should go ahead and do the axillary lymph node dissection. Next slide. Next slide. So this is what this trial might help us to get a knowledge that in case of node positive patient, if node positive patient, if after NACT, if axillary lymph node biopsy is positive, in that particular patient, instead of axillary lymph node dissection, can we get away with radiotherapy? But the results will tell us about it. Next slide. Next slide. So this is the summary what we have already talked. So NACT helps us to sterilize the axilla, and we should always mark the suspicious nodes before NACT. In N0 patient, sentinel lymph node biopsy after NACT is acceptable. Whenever possible, in case of a node positive early breast cancers, before after NACT for sentinel lymph node biopsy, always try to retrieve more than 2 sentinel lymph nodes. Use dual agent mapping and use IHC. Next slide. And it will help us to reduce the removal of marked lymph node will help us to reduce the false negative rates, and the necessary of completion of axillary lymph node dissection in node positive patients is still there. And can we get away with radiotherapy? That the future will tell. Next slide. Thank you.
Thank you, Dr. Sagar. So final talk on this in this session is by Dr. Ajit Gandhi. Dr. Gandhi is Associate Professor, Department of Radiation Oncology at Dr. RML Lohia Institute of Medical Sciences, Lucknow. And Dr. Gandhi will be talking about can genomic risk by used to tailor radiation therapy. Dr. Gandhi, please. Dr. Gandhi, are you there?
Yes, sir. Yes, sir. I'm just unmuting myself.
Sure.
So at the outset, I'd like to thank the organizing committee for giving me this opportunity to be here to discuss a niche topic, genomic risk stratification to tailor radiation therapy. This slide were originally presented by Dr. Philip Portsman at the San Antonio Breast Cancer Symposium 2021. So Tailoring systemic therapy with genomic risk profile is quite well known to us, at least with the molecular classification that we have. We day in and day out tailor systemic therapy with these. Also now the genomic risk stratifications, including the 21 gene panel, and there are several others which has been recommended and supported by several societies to tailor systemic therapies, but the same is not there with the radiation therapy. In essence, radiation acts like a drug, and there is a possibility that we could identify patients where RT is not always beneficial, or we can optimize the risk-benefit ratio. The current RT standards, as we know, is sort of one size fits all criteria because there are some variations, but mostly the choices are not based on molecular or genomic basis. The volumes, the dose, and the indications are also varied across the centers. The initial attempts to identify whether the molecular classification could impact radiotherapy decisions was done by Danish Breast Cancer Cooperative Group, and they tried to evaluate the effect of ER/PR HER2 status on the role of post-mastectomy radiotherapy for breast cancer. They did find out that patients who are luminal A type extracted more benefit from radiotherapy as compared to triple negative and HER2 positive breast cancers. Recent analysis from the HERA trial also found that the patients with node negative did not benefit much from addition of locoregional radiotherapy. And in patients with 1 to 3 positive lymph node patients, there was definitely a decrease in the risk of locoregional recurrence, but the magnitude was lower than the historical studies. So with the changing, systemic therapies, the advancements and more effective systemic therapies, although the benefit is there, but the magnitude of benefit is also decreasing. And the similar is for triple negative breast cancer analysis patients, where it has been found that the effect of radiotherapy benefit is the lesser in magnitude. This was a study which tried to identify a genomic risk profile, which is known as adjuvant radiotherapy intensification classifier, where they included 27 genes. And then they applied it to the SWAG BCG91 RT trial, which was a node 0 breast cancer trial where BCS with or without radiation was given. And they found that in patients where radiotherapy was not given, in the patients with a low Arctic score versus a high Arctic score, the patients with a low Arctic score were more radiosensitive. They were derived more benefit in terms of locoregional recurrence as compared to high Arctic score. So based on this Arctic score classification, there is a sense that maybe patients with a high Arctic score, they demand more dose intensification in terms of either dose, volumes, or whatever it is. And in patients with low Arctic score, maybe there is a scope for a de-escalation of radiotherapy. So this is one of the signals. There are several ongoing trials which are evaluating the role of these genomic risk markers to tailor radiation therapy. One pioneering work was done by Jacob Scott, where they derived a GARD scoring, which is genome adapted radiotherapy dose, which is basically combining the linear quadratic model, several gene expressions based on radiosensitivity index, as well as the standard of care radiation dose. And they again found that in patients who are having a high GARD score, they are probably more radiosensitive. They have got better outcomes as compared to low GARD scoring. Subsequently, in last year, they also published their more results. And maybe it's the time we are beginning to understand that the curve for a particular patient with a particular dose is not always the same, and it may vary from patient to patient. Radiation-induced gene signatures, they are, yes, prognostic and predictive also, and they have been applied to identify pathological complete response, and it was found that they are predictive of death CR rates. Some signatures have also been tried to find out whether we can predict patients who are going to have early recurrence versus a patients who are going to have late recurrence, with implications on radiotherapy decision makings in the future. Pre-op radiotherapy in breast cancer, which is kind of making a comeback, and there are several studies evaluating it. This one study tried to again evaluate patients based on the MAP3 kinase 4, and they found that patients who had a low expression of MAP3 kinase 4, they derived more benefit in terms of a distant metastasis-free survival when treated with surgery plus radiotherapy. However, it is difficult to discern the direct effects of radiotherapy and breast cancer. More so, the interactions are getting complicated with advancements in systemic therapy. The RT effects require a long follow-up, and mostly because radiation is delivered in the adjuvant setting, the effect of radiotherapy immediately is not perceptible. It requires a long-term follow-up, and since the effects are not dramatic, there are few takers to take trials on this. There is, in a sense, opportunity to tailor all of these radiation therapy aspects based on the genomic risk profiles. Like, for example, whether all patients would require the similar target volumes, whether there are patients who can be chosen to de-escalate and escalate in terms of volume or dose. So finally, to conclude, molecular and genomic data guide systemic treatment in breast cancer, and molecular class does have varying effects with radiotherapy, as we have seen from the Danish breast cancer group. The data are limited, but yes, there are promising data on radiogenomic signatures like ARTIC, which we discussed, and the GARD scoring, and it suggests that tailoring is possible. At present, there is no validated biomarker which can reliably predict the benefit derived from radiation at the patient's level. But the future studies are ongoing and may incorporate genomic factors to guide radiotherapy decisions. So this is just for a food for thought. This is one of the studies that we did at our center, where we evaluated XRCC1 gene polymorphism in head and neck cancer patients. Just to highlight that, yes, even in the routine practice in India, we have an opportunity to evaluate this and have outcomes, where we found that patients who are having a wild variant versus a polymorphic variant, the polymorphic variant of XRCC1 had got more toxicities, but they also were having better outcomes. So patients who are having a polymorphic variant of XRCC1 maybe are good candidates for de-escalation of therapy in the future. So it's time that we move on from one size fits all to in the 21st century, where everything is made to measure, and so should the radiotherapy decisions be. Thank you very much.
Thank you, Dr. Gandhi. And this was the last talk of this session. That because as I said, that Dr. Gagan told me that time is quite less, and we are already exceeded the time. So I would like to congratulate all the speakers for their talks and delivering their message in a crisp and concise manner. All the topics chosen by the organizers committee are the very relevant and probably the hot topics of debates. So with this, I would like to conclude, because there are a lot of good, another few topics are also there. I would request Dr. Punita, do you want to say something, Dr. Punita? You are there?
Yes. Yes. Thank you very much. Yes, they were like wonderful sessions and wonderful talks, which we interacted and learned. Please, the thanks, we hand over the stage to the organizing team. Thank you.
Thank you, Dr. Gagan. Thank you. Dr. Gagan?
Thank you, everyone. So without wasting much time, we will move on to our next session, which is life after breast cancer. We've seen how de-escalation is coming forward, but since de-escalation is not prime time yet, we want to still know if there are toxicities, what are these toxicities, and how we can remedy them. So can I invite our two chairpersons, Dr. Indu Bansal. She's the Director and Senior Consultant in the Department of Radiation Oncology at Narayana Super Speciality at Gurugram, and Dr. Sandeep Agarwal, who's a Senior Consultant in the Department of Radiation Oncology, Fortis, Noida. Over to you, both of them, chairpersons.
So good afternoon, everyone, and thanks a lot for inviting me here for this wonderful meeting. And it's a privilege to be a part of this meeting. So without wasting time, I would like to invite Dr. Revati Krishnamurthy, who is Assistant Professor and Radiation Oncologist at Tata Memorial Cancer Center. And she will be talking about life after breast cancer, the state of the heart. So I think it's a very, very important topic. And as Dr. Reema said, that we have to focus on life issues after treatment, because the survival of the patients is increasing. Over to Dr. Revati, please.
Good afternoon, all of you, and thank you very much for inviting me. I'll be presenting a talk which was originally presented by Dr. Carmen Bergom at the 2021 SABCS, which is Life After Breast Cancer, the State of the Heart. So cancer and cardiovascular disease are the most prevalent diseases in the developed world and are fast rising in the developing world as well. And evidence increasingly shows that these conditions are interlinked through common risk factors. And also anti-cancer therapies can cause a wide spectrum of short and long-term cardiotoxic effects. So, which is why the scope of cardio-oncology is wide, and it includes prevention, detection, monitoring, as well as treatment of cardiovascular toxicity, and also coming up with cardioprotective measures to ameliorate the side effects of treatment toxicity. So we have here, so just to, before beginning, just to summarize the known cardiotoxicity of the common breast cancer therapies. We know these figures well, doxorubicin-induced and trastuzumab-related cardiotoxicities, as well as cardiotoxicity of breast cancer radiotherapy, the famous Darby et al., which says 7.4% increase of major coronary events with mean heart dose increase by a gray. The studies we have here today are three. Two are subset analysis or cohorts of the Pathways Heart study, and one is subset analysis of the phase 3 SAFE trial. Moving on to the Pathways Heart study, the Pathways Heart study is an ongoing study where women aged 21 or more with first diagnosis of invasive breast cancer who are members of the Kaiser Permanente of the Northern California, which is a healthcare company, are enrolled. And the questions that the Pathways study hopes to answer are many. So mainly they include, should women with breast cancer eat a particular diet? How much and what type of exercise is best? Are there particular dietary supplements? What role do social and friendship networks play? So these are some of the questions the Pathways Heart study aims to answer. They have almost 50 publications since 2008, and what was presented this year at SABCS is two more. So I wouldn't talk much about this the first one, because it was already described in detail by Dr. Rashi Agarwal. So I would quickly summarize the first one, which is the cardiovascular disease risk of breast cancer therapies by body mass index, where they tried to stratify the risk of certain chemotherapy drugs, the cardiovascular disease risk as well as stroke risk, and it was classified according to the body mass index. And as we saw earlier today, the conclusions were there certain chemotherapy drugs and left-sided radiation may confer a higher CVD risk for breast cancer survivors with normal weight. And there was a paradoxical conclusion there, which was that certain chemotherapy drugs may lower stroke risk for breast cancer survivors with obesity, which they are attributed to something called as the obesity paradox, which is outside the scope of this talk, but it just is something that overweight and obese cancer patients have better cancer survivals for diverse cancers. And this apparent paradox is explained by various methodological limitations, which may make for an interesting reading. The second of the Pathways Heart study, which was presented this year, was the development of cardiometabolic risk factors following endocrine therapy. So we know that endocrine therapy is associated with certain cardiovascular disease risk in breast cancer patients, in breast cancer survivals, and this may be associated with developing cardiometabolic risk factors such as diabetes, dyslipidemia, and hypertension. So all the known studies compare the risk factors of tamoxifen versus AI, but here they compared the risk factors in tamoxifen and AI users versus women who did not use endocrine therapy. And then they stratified it by menopausal status. So the methodology was, as described earlier, the women who were enrolled between 2005 and 2013, and they used various methodologies to identify the cardiometabolic risk factors. The statistical analysis was Cox proportional hazards adjusted for baseline risk. And out of 14,942 patients, 24.9% were premenopausal, and out of which 27.3% used tamoxifen, and 53.5% did not use any endocrine therapy. Their results were that neither tamoxifen nor AI use was associated with risk of developing diabetes, dyslipidemia, or hypertension. And just walking you through this. So as we see, they mainly saw three parameters. So they're mostly eco-related parameters. The 3D LVEF and the global longitudinal strain, which are all eco parameters. So the 3D LVEF, just a second. Sorry. Yeah. So here we saw that AI users had a higher risk, and tamoxifen users had a lower risk of developing dyslipidemia. And for diabetes and hypertension, there was no statistically significant association. So this was their conclusion. It is very important to note that these are abstracts, and it is difficult to form conclusions or conduct a detailed discussion. There are many unanswered questions which the final paper may answer. Moving on to the third study, which is a subset analysis of the phase 3 SAFE trial. Several studies have evaluated cardioprotective strategies to prevent myocardial dysfunction in patients who receive cardiotoxic therapy such as anthracycline, trastuzumab, etc. However, the medical oncologists are yet to come up with optimal solutions like our cardiac shielding and deep inspiratory breath hold. So their search for the optimal cardioprotective strategy is ongoing. So the SAFE trial was a 4-arm randomized phase 3 double-blind placebo-controlled study conducted in 8 centers in Italy. So anthracycline chemotherapy is hypothesized to cause cardiomyocyte injury, and they proposed that angiotensin-converting enzyme inhibitors can prevent cardiac remodeling and reduce mortality in patients with cardiac dysfunction. So their objective was to see whether these pharmacological cardioprevention measures could reduce subclinical heart damage in breast cancer therapy in breast cancer patients treated with anthracycline-based chemo. And the 4 arms were the placebo arm, the ramipril arm, the bisoprolol arm, and the bisoprolol plus ramipril arm. And this particular subgroup analysis studied the impact of post-operative breast radiotherapy in the pre-specified interim analysis of the first 174 patients which they enrolled who completed cardiac assessment at 12 months. And again, these cardiac assessments were 2D echo parameters, mainly LVEF and global longitudinal strain. And they conducted univariate and multivariate analysis with variables including the treatment arm and other risk factors such as smoking, BMI, hypertension. So here you see that 3D LVEF changes from baseline to end of treatment in the bisoprolol containing arm had significant benefit in patients not receiving RT, which is a p-value of 0.009, in patients receiving right-sided breast RT with a p-value of less than 0.001, and to a lesser extent in patients receiving left-sided RT, whereas the global longitudinal strain changes from baseline were significant in the bisoprolol arm in patients not receiving RT, in patients receiving right-sided RT, whereas no benefit was shown in patients receiving left-sided RT, left-sided breast radiotherapy. So here again, we see that the 3D LVEF changes from baseline to end of treatment. So the bisoprolol containing arms had significant benefits. It is important to note that the only trial arm which was associated with GLS worsening was the placebo arm. Logistic regression also confirmed that the placebo arm had a significant higher risk of GLS worsening. So to conclude, cardioprotective pharmacological strategies are well tolerated and seem to protect against cancer therapy-related LVEF decline and heart remodeling. And as I mentioned, the only significant parameter which worsened was in the placebo arm, thus confirming the crucial role of cardioprotection in patients receiving chemotherapy. anthracycline-based chemotherapy. So to conclude, these 3 studies added to our knowledge of ways to improve treatment, surveillance, and cardioprotective therapies. Thank you.
So I think this was a very useful study because it highlighted the importance of ramipril and bisoprolol in patients receiving radiation. But as the study showed, there is not much benefit in patients receiving left-sided radiation. And aromatase inhibitors increase the risk of dyslipidemia. So I think very well presented, Dr. Revati. So next, let's move on to the next session, next talk. Let me invite the next speaker. So now I would like to invite Dr. Lincoln Pujari who is an assistant professor, radiation oncology, HP, CH and MP, MMCC, Varanasi. He would be talking about fine-tuning risk assessment and risk reduction lifestyle, the role of exercise and diet. I think this is a very, very important topic which we should emphasize on our patients. Welcome, Dr. Lincoln, please.
Thank you, madam, for your kind introduction. I'll be discussing about fine-tuning risk assessment and risk reduction lifestyle, mainly focusing on exercises and diet. So coming to the fine-tuning of the risk assessment first. In USA, in a study published in 2019, it shows that the obesity-related cancers, the incidence of these are increasing in the young age population in US population, more so in pancreas, as you can see from here, in thyroid, in kidney cancer, in multiple myeloma, and so on. But in breast cancer, the incidence across the age groups have been stable. But this is not the case while coming to the Asia Pacific population. This is a study by Renahan et al., which shows that they have seen a stronger association in Asia Pacific population between increase in BMI and its relation of increasing in breast cancer, both in patients of premenopausal and postmenopausal age group. Now coming to a study by Rohan et al., which measured the measures of body fat and its relation with breast cancer incidence, in particularly in postmenopausal women. They used 2 methods. One was the dual X-ray energy absorptiometry based methods, which measured the whole body fat mass, the whole body percent fat, and the fat mass of the trunk. All of these 3 parameters and some other parameters correlated well with the increase in risk of breast cancer. Similarly, the commonly used anthropometric measures like body mass index, the waist circumference, and waist hip ratio, these all commonly used parameters also correlated well with the increase in risk of the breast cancer in postmenopausal age group. So how does it happen basically? With the increase in adipose tissue in the body and hyperadiposity, the macrophage gets accumulate in the vicinity, and they lead to an inflammatory condition. By the inflammatory mediators, they can activate the aromatase, and they in turn increase the conversion of androgen to estrogen, which is the main source of estrogen in the postmenopausal age group. Apart from this mechanism, there are some other mechanisms like the effects on the glucose metabolism by increasing insulin and insulin, like insulin growth factor 1 and others, which increase in the cancer. In the breast, it is called as white adipose tissue inflammation, and it is mainly seen by this crown-like structures in the histopathology, which are basically the accumulation of the macrophage around the adipocytes. In the humor HE stain, it can be seen, and more so in the anti-CD68 immunohistostaining, it can be seen more clearly. So now coming to the study 2017, which compared the evidence of adipose tissue inflammation in benign breast disease cohort and compared those benign breast disease patients who did not progress to have malignant cancer, and as compared to those patients who progressed to have malignant breast cancer. So among the benign breast disease biopsy, a high crown-like structure count of more than 5 was seen more in patients who progressed to have malignant breast cancer rather than those who didn't have this count. And it remained significant when they were when the factors like adipose tissue area, the histopathological impression, and the body mass index was taken into account. So the high crown-like structure densities are independently associated with an increased breast cancer risk, and they may be a promising histological marker of breast cancer risk in patients having benign breast diseases. This this adipose tissue inflammation can have an effect on the breast cancer outcome also. According to this publication by Sagar et al. In 2015, in univariate analysis, these patients who were having the crown-like structures were having a median distant relapse-free survival of around 20 months, as compared to those patients who didn't have this adipose tissue inflammation of 26 months. And this remains significant also in the multivariate model. Among the obese patients, some of these may have healthy metabolism, and those patients who are having a normal BMI may also have metabolic obesity. This can be seen, and the breast white adipose tissue inflammation occurs in approximately 1/3 of the women with normal body mass index. Now coming to the normal weight hyperadiposity and postmenopausal breast cancer risk. In this study published in JAMA Oncology in 2018, this study took into account the DXA measurements of whole body fat mass, whole body fat percentage, and fat mass of the trunk, and it showed that a 5-unit increase in the whole body fat mass was associated with 28% increase in the risk of invasive breast cancer. Similarly, a 5-unit increase in the whole body fat was associated with 19% increase in the risk of invasive breast cancer, and 5-unit increase in the trunk fat mass was associated with around 46% increase in the risk of invasive breast cancer. Now coming to the risk reduction strategies. This was the guideline published in 2018 by World Cancer Research Fund and American Institute for Cancer Research. They took into account around 10 factors. 7 of them were like modifiable factors, and 3 of them were not. So to name them, to have the normal healthy weight is important factor, to be physically active, to eat a rich diet with plant-based products, limit the consumption of fast food, limit the consumption of processed and red meat, limit the consumption of the sugar and sweetened drink, and limit consumption of alcohol. These 7 were the modifiable factors. Apart from them, the not using supplement for cancer prevention, breastfeeding the baby, and following recommendations after diagnosis was also important to reduce the cancer risk. Sams White et al. Proposed a adherence score in their publication in 2019, giving one maximum score of 1 to the 7 modifiable factors, and if we include the breastfeeding, then the total score increases to 8. The maximum score increases to 8. So this prospective scoring can be used in the population-based study to assess the adherence to the recommendations. Apart from this, in this study, in this meta-analysis of 38 studies, including more than 1 lakh breast cancer patient by Pijo et al. In 2016, they included the studies across the globe, published from 1987 to 2014. And as per this study, increased level of physical activity led to reduction in the risk of breast cancer, irrespective of the type of physical activity the amount of physical activity, it was seen across the globe, and irrespective of the adiposity, irrespective of the menopausal status and the hormonal receptor status of the tumors. And the breast cancer risk seemed to decline with the increasing physical activity without any threshold effect. Though this benefit from the physical activity was not evident in patients who had ever used hormone replacement therapy during their lifetime. Now coming to the diet recommendations in particular. In this article by Baden et al. In 2019, they divided the plant-based diet into two main groups. One is healthful and unhealthful. The healthful plant-based diet, they included the non-processed whole grains, vegetables rich in fibers, and fruits. And unhealthful plant products included that processed food, the sweetened drinks, fruit juices, etc. And according to this article, there was a definite increase in the inflammatory markers when there was an increase in intake in unhealthful plant-based diet index, as can be seen from this increase in the leptin, the CRP, the IL-6, the leptin-free index, etc. And correspondingly decrease in these inflammatory markers when we take the healthful plant-based diet, and increase in the adiponectin level also. So to conclude, we should be aiming to maintain optimal body fat and lean mass ratio. Simple anthropometric measures are good enough to detect the body fat. Encourage healthy plant-based eating patterns rather than specific diets as of now until further clarity emerges on this. Physical activity of any type reduces the breast cancer risk in all the age group across all population. And population-based lifestyle modification and healthy lifestyle promotion programs are needed to increase awareness among public in general. Thank you.
Very nicely presented, Dr. Lincoln. So I think that was a very useful message that we have to educate patients to continue healthy lifestyle and focus on exercise and physical activity and take more of plant-based diet, because we now have a good evidence for exercise and reducing breast cancer mortality. So very well presented, Dr. Lincoln. Now I would like to invite my co-chair, Dr. Sandeep Agarwal, to carry on the session, please. Dr. Sandeep.
Yeah. Thank you, Dr. Indu. And congratulations to all the faculty for very good presentations. Now we are discussing about quality of life issues and rehabilitation part of carcinoma breast, and a very interesting and something which is really not discussed in our conferences is acupuncture. Let us see what Dr. Surabhi Gupta, who is Professor Radiation Oncology at SN Medical College, Agra, have to tell us about this topic. That is acupuncture for breast cancer patients. Over to Dr. Surabhi.
Thank you, sir. So first of all, good afternoon to everyone. And thanks organizers for giving me this opportunity. So I'm here to discuss, basically, given an overview of this phase 3 randomized control trial on acupuncture for the chemotherapy-induced peripheral neuropathy and neuropathic pain. So in her trial, basically in her talk, Dr. Ting has given an overview of the acupuncture. First of all, we should know what is acupuncture. Basically, this is the Chinese medicine devices which use very thin stainless steel needles which are inserted and manipulated into the body, into the some points. When this device is associated with some electrical current, this is called the electroacupuncture. There is another word, that is the sham acupuncture, which I will discuss later on. Basically, sham acupuncture is a type of the placebo, with a similar type of needle are inserted into the body, but at different points other than the acupoints. So what are the acupoints? These are the very high...
Slides are not moving.
Yeah, I'm on the same slide, ma'am. Acupoints are the high density of the neurovascular structures, which are generally situated between the muscle group or at the edge. These have the low electrical resistance. There are various hypotheses regarding the function of the acupuncture. According to some, it acts through the neurohormonal pathway, which activate the hypothalamus, pituitary gland, and change in the neurohormonal peptides like beta endorphin and enkephalin. According to some, it manipulates the neurotransmitters and activates the brain-derived neurofactors. Neurogate theory, which says that non-painful stimulus block the pain perception. It stimulates endogenous pain inhibitor pathway and produces the analgesic effect.
Dr. Surbhi,
yeah, ma'am.
Your slides are not moving. You are still on the first slide.
It is showing me. Now it's moving, ma'am?
No.
What is showing here?
Dr. Surbhi, please.
Can technical person can take care of this? It's not moving here.
Dr. Surbhi,
now it should move. Try scrolling, Dr. Surbhi, please.
No, it's not moving. Yeah. And now you can see it's moving.
It's moving now.
It's moving now. Okay. So it acts also to the immunomodulation and changes the cytokines concentration, interleukin 2, 6, 8, and 10. It also modulates the brain activity, which can be well depicted to the functional MRI studies. It's moving now?
It's moving.
Yeah. So we know that breast cancer survival has to undergo the aromatase inhibitors, and the most common complication of aromatase inhibitors are the musculoskeletal pain. Sometimes it's so severe that most of the patient has to discontinue the aromatase inhibitors use. So there are various studies which have shown the use of the real acupuncture and compared to sham acupuncture and weightless control. So Crew et al. Has shown that real acupuncture has the good response as compared to sham and other, while other 3 studies have shown that real acupuncture is equivalent to the sham acupuncture, but both of these modality is better than the weightless control. So acupuncture, another study by the Hirschman et al., which was published in JAMA, which has shown that acupuncture has statistically significant reduction in joint pain, which was the aromatase inhibitors used, and it was persistent up to the long-term follow-up. We can see here that 2-point reduction in the pain scoring is much more in the 2 acupuncture arm as compared to sham or weightless control. Another trial, that is the PEACE trial, which was done basically again for the musculoskeletal pain among breast cancer survival, which compared the electroacupuncture with the auricular acupuncture and usual care. So both of these interventions have shown that there is an improved pain-related function interference and improved physical and mental quality of life. And up to week 12, there were reduced analgesic use, and it was continued up to the week 24. It means its response was consistent. Adverse effect is seen both the arm, but it was more in auricular acupuncture arm, but it was mild. But 10% of patients discontinued this treatment due to the discomfort. Another symptoms which has seen in breast cancer survival is the vasomotor symptoms, that patient present with the hot flushes, night sweats, and this is due to the use of the endocrine therapy. Symptomatic management, though challenging, estrogen therapy we know is the most effective treatment modality in this patient, but it is associated with increased risk of recurrence as well as development of the new breast cancer. So what is the option? Integrative medicine therapy may be the another option for this type of the patient. There are different trials which has been done regarding this management of hot flushes, and these trials basically compare the real acupuncture with other alternatives like sham acupuncture, gabapentin, venlafaxine, and most of these trials have shown that real acupuncture has shown the good result, and shown the symptomatic benefit in the patient when compared to other comparative arm. Another trial, that is the acclimate acupuncture trial, which has also shown that combined therapy in the form of individualized acupuncture and self-care regime has shown the much better response, much better, and the more consistent response up to 6-month follow-up as compared to enhanced self-care group alone. Insomnia is another symptoms which are seen in our breast cancer survival patients. So there was another study that is called the CHOICE, which has compared primary endpoint of this study was 8-point reduction in insomnia severity index. So these trials have so shown that acupuncture as well as the cognitive behavior therapy for the insomnia, both have shown the good and consistent response, but they prefer that CBT is more effective in the white male educated patients and patients which are not having the pain. Yeah. Now coming to the CIPN, that is the chemotherapy-induced peripheral neuropathy and the pain. So various modality has been used for this CIPN, acupuncture, and as well as the duloxetine, but there was no head-to-head comparative trial of these modality, but individually both of these modality had changed the regression of the pain score in both the arms, duloxetine having the more side effect in the form of fatigue, insomnia, nausea, but acupuncture is showing the mild bruising only. Another trial was, this was the phase 3 pilot randomized trial, which was done by Bio et al. And they have shown that therapeutic benefit of the real acupuncture for neuropathic pain is consistent with previous pilot acupuncture of CIPN trials when compared to sham and the usual care arm. So keeping in this mind, Dr. Ting Bao has designed this ACT scheme. This is the randomized phase 3 clinical trials, which is for the acupuncture for chemotherapy-induced peripheral neuropathic pain. So this is currently undergoing trial, and its started date was 21st May 2021, and estimated study completion date is 21st May 2025. So they have basically targeted to enroll 250 breast cancer patients who has completed their neurotoxic containing chemotherapy at least 3 months prior to the enrollment in the study. And patient must be having the moderate to the severe neurological neuropathic pain. And these patients should not be having the pacemaker and should not having the electronic medicine devices. So these type of patients are excluded from the study, and also patients should not take in acupuncture therapy for any reason, at least within the 1 year of the enrollment. So randomization is basically will be done in the 2 arms. First arm is the electroacupuncture and the another is the sham acupuncture. In both of these arms, patient will receive 10 sittings of the intervention. Within the first week, they will receive twice weekly. After the up to the 8th week, they will receive the once weekly. So that's committing total 10 sitting in each arm. So assessment will be done basically difference of the pain severity from the baseline to 8 weeks. After baseline, that is a time frame. Time frame is the 8 weeks. And primary outcome will be the patient's rating his or her average pain within the past 24 hours. All participants will fill out the brief pain inventory short form. So this is the undergoing trial, so we cannot comment on result. So coming to the summarize the things, healthcare provider should be aware that acupuncture possesses the minimal risk. Though some serious adverse effect has also been seen like pneumothorax, broken needles, infection, but these incidents is very rare. Minor side effects are usually seen like mild bruising and the mild bleeding. But we must see that it carries a potential significant benefits, and it may be a reasonable treatment option for breast cancer survival to alleviate treatment-induced side effects like musculoskeletal pain, hot flashes, insomnia, and most probably in chemotherapy-induced peripheral neuropathy and neuropathic pain, though additional studies are needed to comment on this. So my take-home message is that acupuncture is a fascinating option for CIP management, but it will be too early to recommend its use for clinical practice. Thank you.
Thank you, Dr. Surbi, and a very interesting perspective on quality of life after treatment of breast cancer. I think it needs further evaluation till it comes to practice, where it at least said by you. So thank you very much for the excellent presentation. Now I invite Dr. Monideepa Mandal, who is consultant radiation oncology in Narayana Super Specialty Hospital, Kolkata. Now, the discussion will be on monitoring of advanced breast cancer with liquid biopsies. Can we demonstrate a clinical utility? So, Dr. Monideepa Mandal, please. Dr. Monideepa?
Yes, sir.
Yeah.
Thank you for the respected chairperson. Thank you for the introduction and thank you for the organizers for inviting me. So today I'm going to discuss that whether monitoring of the adverse breast cancer with liquid biopsy can we demonstrate clinical utility. It was initially presented in ACBCS Conference 21 by Dr. F.C. Vidat from Institut Curie, France. And we know now that the breast cancer treatment is becoming more and more individualized, and liquid biopsy is one of such tools in the armamentarium of the precision medicine, and it is a minimally invasive tool where we detect the ctDNAs and also the circulating tumor cells that are released from the primary tumors and the metastatic tumors to the bloodstream, and thereby if the CTC counts are rising, we can detect the early relapse of the tumor, which opens up a new window of opportunity. Also, the ctDNAs can be analyzed for tumor-specific mutations that are responsible for treatment resistance. So as the tumors are evolving over time, the real-time assessment of the tumor dynamics help in monitoring the treatment efficacy. But does doing all this, we prolong the survival of the patients or we delay the progression? It need to be seen. So the clinical utility has to be seen in clinical trials. So I'll be basically discussing my topic on these three broad headings and will be emphasizing my talk on two important trials which was presented in SABCS 21, that is C-TRACK-TN trial and also the PADA-1 trial. Next thing is that the C-TRACK-TN trial, the background is formed by the fact that ctDNA can help detecting the metastatic relapses or the relapses much earlier, and much earlier than that is predicted by the symptoms or by doing imaging. So this gives us a new window of opportunity. And if we intervene in this window of opportunity, does we have a clinical benefit to that? If we give a rescue therapy immediately, does we have a clinical benefit to that? So this is the C-TRACK-TN trial. It was conducted by the Turner and his group, phase 2 multicentric trial. And it is conducted in moderate to high risk non-metastatic triple negative breast cancer because they are at high risk of developing relapses more higher than the other subtypes. And following the primary treatment, they underwent an active ctDNA surveillance at the baseline and 3 monthly. And those who were ctDNA positive within 12 months, they were randomized either to observation or to interventions. Now, 208 patients were initially included, and after 12 months, 52 patients were ctDNA positive. And those who underwent randomizations, the patients who underwent into the intervention arm, 70% of the patients were found to have metastasis by imaging. And they were too late for the rescue therapy. Only 4 patients were started on the rescue therapy, which was pembrolizumab. So the results of the C-TRACK-DNA trial with a median follow-up 20.4 months shows that the proportion of ctDNA positivity by 12 months was much higher in the high-risk patients group. But at the time of ctDNA detection, a relative high rate of undiagnosed metastasis was there, which was detected in the imaging. So the interventional arm, that interventional therapy, didn't show any potential activity. But this trial had some implications for future trials. That means starting the ctDNA testing earlier in adjuvant setting might help, and more frequent testing might help. Also, using of more sensitive ctDNA assays to track the variants will be helping. And therefore, the C-TRACK-DNA trial, it can form the basis of the future trials. So other trials which are being conducted in the advanced breast cancers are actually advanced breast cancer without having symptoms or radiological evidence of disease progressions are Persevere trial, Artemis trial, ZEST, Aspiria, and their TRACK-ER trial. Of this, the ZEST trial is a phase 3 trial which is conducted in BRCA positive BRCA positive group, TNBC group, and late rescue therapy with niraparib was given. So next thing is whether monitoring this breast cancer patients who are having overt advanced disease helps. Now, the answer from this question comes from the STI-CTC trial, which is conducted in 778 patients of ER positive, HER2 negative breast cancers. And this trial was conducted in the pre-CDK4 inhibitor ERA. And this trial was looking at whether CTC-driven treatment choice was non-inferior to the clinical-driven treatment choice. So here, the hormone receptor positive, HER2 negative patients were then randomized to the standard arm or the CTC-driven arm. In the standard arm, the patients received the chemotherapy or hormonal therapy based on the clinician choice, which is actually based on certain clinico-pathological prognostic variables. And in the CTC arm, they received treatment according to the CTC levels. That means high CTC levels are going to get the chemotherapy, and low CTC level, they are going to get the hormonal therapy. Primary medical endpoint was the progression-free survival. So the result of this study showed that the CTC-driven treatment choice is non-inferior for progression-free survival in metastatic breast cancer in ER-positive HER2 negative setting to that of the physician-driven choice. But more importantly, they find that in the discordant group, where the CTC levels were high, but the clinical risks were low, the PFS were longer with chemotherapy, and in those subgroups where CTC levels were low, but the clinical risk was high, the PFS was not shorter with endocrine therapy. So also this analysis of the recent unpublished study shows that similar trend was found in OS also, but it should be taken with caution because this study was done in the era where before CDK4 inhibitor era, and also we should say that this CTC driven choice was not based on the primary analysis was not based on the OS, but it was based on the PFS, so it was not adequately powered for OS. And second important thing is that the CTCs can also detect the primary resistance in a way that if the patient is continuing a line of therapies and there is lack of early decrease of the CTCs, then we can say that there is a primary resistance, and then we can shift to the second line therapy. Some important trials are undergoing, some trial results have already come. One such trial is the SWOG 0500 trial, where switching to the second line therapy was tested, but there was no gain in the survival. Another trial which was conducted based on the same thing showed a poor compliance and slow accrual. There are some important trials which are ongoing, that Mondrain trial and Sapphire 03 trials. Another important trial which has to be discussed in this point of view, and also it has been discussed in this SABACS, is the detection of the secondary mutations, secondary resistance to the endocrine therapy by detecting, does it have a clinical utility or not. So the study is the CATA-1 study. Now we know that ESR1 mutation is associated with endocrine resistance in those hormone receptor positive advanced metastatic breast cancer. So in metastatic breast cancer who were hormone receptor positive, HER2 negative, and who were on the first line therapy with AI and one of the CDK4 inhibitors, they received they underwent ESR1 mutation detection testing serially, and if there was no synchronous progressive disease, then they were randomized to continue the same therapy or switching off to the fulvestrant plus palbociclib arm. And the results, which were early results of 26 months follow-up, showed that switching to the fulvestrant and palbociclib resulted in a doubling of the PFS almost. And those patients who continued in the AI plus palbociclib arm, they were allowed to cross over, and the second line PFS came to be around 3.5 months. So this was the first study to show that change in the first line therapy in hormone receptor positive metastatic breast cancer based on the resistant tumor marker rather than the imaging confirmation of the progressive disease have a clinical utility at present. And to conclude, I will say that disease monitoring helps open a new window of opportunity. When metastases are still asymptomatic, we can escalate the adjuvant therapy. We can give earlier rescue therapies. The prognostic assessments help in harmonizing the treatment decision, and it also helps in the response monitoring. More and more clinical trial has to come up to prove its clinical utility. And my take-home message is that from what it is CTCs and ctDNAs, they are definitely validated independent prognostic markers. But from PADA-1 study, we have seen that in the endocrine resistant setting, particularly using 1/5 line of therapy, that means giving another therapy when the ESR count, ESR mutations are detected, it opens in the new window of opportunity. It provides a gain in the PFS. This might not catch up when we wait for the progression and give second line therapy. Also, that the CTCs, DNAs, CTC and ctDNAs, they are reliable and reproducible biomarkers for guiding treatment choice in first line hormone receptor positive. Also should emphasize that the design of the clinical trials based on the biomarkers, it has to be something different from the acceptance will be later, but we also need to incorporate the cost analysis, cost benefit analysis as one of the endpoints of these trials. And so we are at the dawn of the personalized and precision medicine. A lot of more things are going to come, and then we can say that there are clinical utility and we accept it in our general practice. Thank you.
Yeah, thank you, Dr. Nidipa. And may I ask the organizers, do we have time? Hello? Yeah,
Dr. Sandeep, sorry, I didn't get your question.
I just wanted that, do we have time for questions or should we wind up the session?
We are running 25 minutes late already. So,
okay.
So the panel discussion will get cut short badly. So we are wondering, so we are just hoping that everything can be resolved with the panel discussion. That's quite extensive.
Yeah.
That was the third.
Thank you, Co-Chairman. Thank you, Dr. Gagan, and thank you, presenters, for excellent presentations. We can have questions in the panel discussions. Thank you very much.
Thank you so much, organizers and the expert speakers. Thank you.
So it's time to move towards the last session also, and we will be hearing interesting data on brain metastasis, leptomeningeal metastasis, and the role on local therapy in stage 4 cancer. So for this session, I would like to invite the chairperson, Dr. Kishore Singh, who is the professor and director at Maulana Azad College, Delhi Cancer State. I would hand over the further. Dr. Saroj is unable to join us. Dr. Saroj is unable to join us for some reason.
Good afternoon. This is session 3. This will include 3 abstract presentation and followed by the panel discussion. Since time is short, so request presenter to stick to the time schedule and finish early possible. So first presenter is Dr. Arpita Bindal Gupta. She is consultant at Fortis Noida, and I request her to present the first abstract on breast cancer subtypes and brain metastasis.
Thank you, sir, for the kind introduction. I hope I'm audible and my screen is visible.
Yes.
Thank you. I would like to thank Dr. Rima and the organizers for giving me this opportunity to present this very interesting data from the GAICAM group on breast cancer clinical subtypes in brain metastases patients. These days, oncologists, in order to understand the kinetics and dynamics of brain metastases in breast cancer patients, are resorting to maintaining registries of specific subgroup of patients. An example is the French ESME MBC cohort that includes more than 16,000 patients. And from their data, we come to know that the risk of developing brain mets in metastatic breast cancer patients is about 25%. They develop it at an average of 2 to 3 years after the initial breast cancer diagnosis. And in the recent years, with improvement in systemic therapy, the frequency has increased since the patients are living longer. The outcome still remains poor with the 1-year OS of about 20%, but it's still variable depending on the subtype. Now, this study, the study, is a privileged cohort study that done 2019. 1,902 patients were accrued, and the eligibility criteria was unresectable locally advanced breast cancer or metastatic breast cancer patients, either at recurrence or as first diagnosis. They were clinically subtyped based on the most recent tumor lesion into luminal, HER2 positive, or triple negative breast cancers. And out of these 1,902 patients, about 218 patients developed brain mets, and this analysis tries to delve into the details of these 12% patients. I would not spend much time on the characteristics of advanced breast cancer diagnosis because they are more or less similar across the subgroups. A certain pertinent points would be that triple negative breast cancer patients had a slightly higher propensity of developing brain mets at advanced breast cancer diagnosis, which was 46% as compared to 37% and 34% in the other two subgroups. Most of these patients had early breast cancer at initial diagnosis and developed advanced breast disease more than 12 months after the initial diagnosis. Very interesting was that they also expressed results as with respect to the brain metastasis development. So they categorized patients into patients who had brain metastases at the time of advanced breast cancer diagnosis and patients who developed brain metastasis later, maybe a few months after advanced breast cancer diagnosis. There were more patients in the latter category, and there was not much difference in between the two in terms of age, menopausal status, or stage at initial diagnosis. Then they have told us what was the systemic therapies given in the first, second, and third line given to these patients. The most common was for luminal aromatase inhibitors with dual anti-HER2 blockade, and for triple negative it was single-agent chemotherapy. The median duration of treatment was about 12 months for HER2 positive patients, and for the others it was around 5 to 7 months. Similar was the time to progression, which was the best with the HER2 positive patients, and it was 6 months with triple negative breast cancer patients. Subgroup, if we see in patients who had only brain mets at advanced breast cancer diagnosis, the time to progression was a little lesser by about 3 to 4 months. Next, they have talked about the median time from diagnosis to development of brain mets. So they have primarily categorized patients into 3. Patients who had primary breast cancer were treated and then later developed advanced breast cancer with brain metastasis. In such patients, the median time from diagnosis to brain mets development was maximum 54 months for luminal subgroup, 30 months for the HER2 positive, and 18 months for the triple negative breast cancer. The second category was patients who had early breast cancer at presentation, were treated, then presented with advanced breast cancer disease, but did not have brain mets at that time, and later was developed brain mets. In them, for the duration between diagnosis of advanced breast cancer disease to development of brain mets was the least. If we compare the 3 subgroups, it was 18 months for luminal, 14 months for HER2 positive, and 10 months for the triple negative. The third category was patients who had de novo metastatic breast cancer disease and later developed brain mets. They did slightly better than the patients who had early breast cancer at presentation, 27 months, 28 months, and 10 months. This was the duration between diagnosis of advanced breast cancer to development of brain mets. The overall survival, as seen from the detection of brain mets, was 6 months for luminal, 11 months for HER2 positive, and the least at dismal 4 months for the triple negative breast cancer patients. So death was seen in about 74% of this subpopulation, and the triple negative breast cancers, as expected, fared the worst, with 95% of them succumbing to disease. The overall survival from brain mets diagnosis was 13 months in patients who had brain mets when they presented with advanced breast cancer. And it, on multivariate analysis, they saw the what was the time to brain mets development. De novo metastatic breast cancer patients were associated with longer time to brain mets development, and the triple negative subtype was associated with a shorter time to brain mets development after advanced breast cancer diagnosis. Looking at the overall survival, brain mets after advanced breast cancer diagnosis and the triple negative subtype compared to the luminal subtype had worse survival, and metastatic locations or number of brain mets, they did not were not statistically significant. So to conclude, more patients develop breast cancer brain mets after advanced. Considering all patients, irrespective of the breast cancer subtype, the overall survival from the brain mets diagnosis is longer in patients who have brain mets at the time of advanced breast cancer diagnosis as compared to patients who develop it later. In patients with de novo metastatic breast cancer, they develop who develop brain mets later than patients with patients who have early breast cancer and then present with recurrence. Triple negative breast cancer is associated with a shorter time to breast cancer brain mets and worse outcomes as compared to the other subtypes. Thank you.
Thank you, Dr. Arpita, for completing well in the time. I wanted much in the comments on this slide, except that unfortunately 80% of brain mets are metachronous. But good thing is 70% of them are oligometastatic, so they are treatable. And you rightly said worse is the HER2, followed by TNBC. But the study which I saw, one says that the best, or you can say the longest median survival is in the luminal B, followed by HER2 positive. So again, thank you for your presentation. And I will call the next abstract on leptomeningeal metastasis by Dr. Shreyashi Karmakar. She is working in consultant at Kokilaben Dhirubhai Ambani Hospital, Mumbai. Dr. Shreyashi, please.
Hello, am I audible and visible?
Carry on.
Good afternoon, everyone. At the onset, I would like to thank the organizers for giving me this opportunity. So today's topic is response according to the revised RANO criteria is associated with overall survival in patients with leptomeningeal disease. So around 5 to 10% of solid cancers usually present with leptomeningeal metastasis, and the response evaluation, and they usually have a very dismal prognosis. The response evaluation of leptomeningeal disease is challenging, and there is no or little consensus to it. And also there is lack of standardization for assessing response post-treatment in patients with leptomeningeal disease. So in 2017, Rune et al. Had given the clinical practice guidelines in the ENO-ESMO, in which they had grouped patients with leptomeningeal disease as type 1 and type 2. Type 1 patients are the ones who had positive CSF cytology or positive biopsy, and type 2 were the ones who had clinical findings and neuroimaging only. Further, based on the MRI findings, they had divided the patients as type A, who had linear MRI abnormalities, type B, who had nodular disease only, type C with both linear and nodular disease, and type D, who did not have any MRI abnormalities. Further, they had grouped the patients with leptomeningeal disease at confirmed, probable, possible, or no lack of there's lack of evidence. This study was validated in 2020 again by Rune et al., in which they had seen that the confirmed, probable, and possible leptomeningeal diseases, as well as the type 1 and type 2, they're significantly associated with the overall survival of the patients. In 2017, Chamberlain et al. Had also proposed a RANO response criteria for assessing the leptomeningeal metastasis post-treatment, in which they had considered neurological examination of the patients, CSF analysis, and complete contrast-enhanced neuroaccess MRI. Based on these findings, they have developed a scorecard. However, the validation of this study was required. So in 2019, Rune et al. Had assessed the feasibility of the previous study, and they explored the feasibility, and they had included 10 neuro-oncologists and 9 neuroradiologists, and the 20 MRIs of 22 patients were evaluated both as baseline and at the follow-up, and they were given LANO scorecard to assess the patients. It was seen that there was quite a lot of inter-observer disagreement, as we can see here, and this was regarding all the items in the scorecard. So they concluded that the scorecard was not useful either for current clinical practice or for any clinical trial. Based on their findings, they further made they proposed a new scorecard in which they had simplified the previous items, and in the brain, they had included nodules, leptomeningeal linear enhancement, and hydrocephalus. And instead of scoring them individually, they had given as improved or no change and worse. And based on this, a new scorecard was given. However, for this also, further validation was required. So in the present abstract, which was presented in the SAPCS 2021, they had evaluated the response according to the revised RANO criteria given by Rune et al. In 2019, and they tried to find if there is any association with overall survival in breast cancer patients with leptomeningeal metastasis. So they included consecutive patients of leptomeningeal metastasis from breast cancer from 2 premier institutes in Italy and France. They included patients who had available baseline brain MRI. Overall survival was defined as the time interval between baseline MRI and death or the last follow-up. So baseline and first available follow-up MRI scans were centrally reviewed by a dedicated radiologist using the 2019 revised scorecard. So they had accrued 225 patients, out of which baseline MRI was available only in 142 patients, and further only 60 patients had available follow-up brain MRI. Coming to the results, only the 60 patients had follow-up brain MRI, and this drop-off was mainly due to either deteriorating performance status or death. At the last follow-up, 138 of the patients out of the 142 patients had died, and the median overall survival was only 5 months. It was seen that presence or absence of a positive CSF cytology did not impact the overall survival, even in the overall patients, nor in the patients who had a follow-up MRI. Between the groups of patients who had follow-up MRI and no follow-up MRI, there was a significant difference in the patients based on the phenotype and HER2, the hormonal status, and also based on the types of the MRI findings based on ESMO leptomeningeal types. It was seen that the patients with follow-up MRI had a significantly longer overall survival than patients with no follow-up MRI, which is quite understandable. And the median overall survival in patients with MRI was 15.2 months versus 2 months only in patients who did not have a follow-up MRI. The only clinical variable associated with overall survival in the subgroup of patients with follow-up MRI was the presence of neurologic symptoms at the diagnosis of the leptomeningeal metastasis. The patients who had a leptomeningeal symptoms of neurologic symptoms at diagnosis had a 14.9 months of survival compared to those who did not have and it was 17 months. So as we can see, based on the scorecards of the 2019 RANO response criteria, there was a significant difference in the survival, with the patients having progressive disease faring the worst, and the better survival was seen with those having complete response. The patients with complete response, as per the 2019 RANO criteria, it was 31.1 months, and those who had a progressive disease had only 9.5 months of survival, median survival. The treatment offered in the group of patients was quite heterogeneous, and on analysis, it was seen only that systemic chemotherapy and hormonal therapy were the only treatment modalities which were significantly associated with better overall survival. So to conclude, it was seen that despite its dismal prognosis, a selected group of patients with leptomeningeal disease, breast cancer related leptomeningeal disease, can achieve a prolonged overall survival. And this study validated the 2019 RANO revised response score, and they further validated and they commented that it can be used in the real world cohort, and they supported the use in clinical trials also. So the take-home message is there is still lack of standardization for assessing response post-treatment in patients with leptomeningeal disease. With improved therapeutic strategies, a certain cohort of patients with leptomeningeal disease can have a better survival outcome. This study validated the revised RANO 2019 scorecard. However, further studies is still warranted in larger cohort of patients.
Thank you, Dr. Shreyasi, for crisp presentation. Leptomeningeal mets are least common and they are non-measurable. So RANO made an attempt to make it a subjective criteria, to make it some kind of response card. There is individual variation from observer to observer, and one study has said that radio-oncologists are better in scoring than the radiation oncologists. So there is still validation need to be done. And with this, I call the third speaker, Dr. Rashmi Shukla. She is consultant at Max Super Specialty Hospital, Patparganj, to speak on loco-regional treatment of de novo stage 4 breast cancer.
Hello, a very good afternoon to all of you. Sir, am I audible, sir?
Carry on.
So, Palak, can you please share my slides? So, a very good afternoon to all of you. I am going to speak on the primary site local therapy for de novo stage 4 breast cancer. So the results of the prospective clinical trials. Next slide. So about 6% of new breast cancer diagnoses in US are stage 4, and the median 3-year survival in 2011 was 40%. But in these patients, the intact primary tumor, it aids in diagnosis, as well as the biologic subtypes also influences the selection of systemic therapy, as well as it can cause various symptoms and affect the quality of life. Till 2001, there is no formal analysis of the value of local therapy to the primary site in the stage 4 breast cancer patients. Next, please. So the NCDB data 1990 to 93, they analyzed the survival in stage 4 patients. They found that the median survival even in total mastectomy patient is 13.9 months and have the significant benefit in negative, positive and negative margins. Next slide, please. So the primary tumor resection in stage 4 breast cancer, is there a consistent benefit or there is a consistent bias? Next, please. So the sources of biases in the retrospective data, it might be the better physiology like age, comorbidities, better access to care like invalid or insured, or a better biology of tumor like hormone receptor, HER2 status, grade, or might be due to lower metastatic burden like there might be bone-only disease or oligometastatic disease. These are at best only approximately measured in retrospective data. Next, please. So in NCDB data 2021, the new retrospective analysis, they have analyzed 12,838 patients. They divided into two arms, one in systemic therapy alone, systemic therapy and radiation, and the next arm they have divided systemic therapy and surgery, systemic therapy, surgery and radiation. Next slide, please. Based on this data, the main message of this paper is that the trimodality therapy is the best with chemotherapy when it is given before the surgery. But the surprises are that the oligomeds in 38% of patients in these paper, and the systemic therapy used in 28% of patients in 2010 to 11, and from 28 it is increased to 40% of patients in 2014 to 2025. Radiation as locoregional seems undistinguishable from radiation at the distant sites. Next slide, please. So, the various prospective trials which are addressing the use of locoregional therapy for the intact primary tumor. Next, please. So there are few randomized and non-randomized trials like Tata Memorial MF0701 positive E2108 JCOZ 1017 and two non-randomized, that is TBCRC and MF1401. So next please. So the randomization design in all these groups, they have divided into two designs. Like first, they are registered the patient and given the primary systemic therapy, and the second registration if there is no progression. And in the second design, they have registered the patient into systemic therapy alone, and the second arm is resection of primary tumor upfront, and further they continue the systemic therapy. Next, please. So the trials with the upfront systemic therapy, the two trials like from Tata Memorial from India and E2108. So in Tata Memorial paper, they have included the resectable post-anthracycline based chemotherapy. And they have included less than 3 organ sites, no extensive liver mets. They excluded if single metastatic lesion or amenable to local therapy. In E2108, the resectable post-physician determined optimal systemic therapy, and all patients, they must have the expected survival of more than 6 months, and biopsy is required if single metastatic lesion. Next, please. So, in both Tata Memorial and Gayakuad 2108, they have done a registration at first step and second, then randomization in second step, and then they divided the arms into continue the systemic therapy and in second arm the early local therapy. And in the local therapy, they have done MRM or BCS plus minus and axillary dissection plus minus post-op RT as for non-metastatic disease. Both arms they have designed in the same way. Next slide, please. So in both, they have used the upfront systemic therapy and they found that there is no survival advantage benefit in both the Tata Memorial as well as EA2108 trial. Next, please. So in the next trial, the Turkish Federation MF07 and ABCSG28 positive trial. So Turkish has reached its full accrual. They again have randomized in continuing the systemic therapy and the second arm, the early local therapy, and they have analyzed the efficacy analysis population. And in positive trial, it is halted for low accrual and they have only included the 90 patients. And in the same way of randomization they did, and in local therapy, MRM or BCS or sentinel lymph node biopsy if allowed, then axillary dissection if indicated, and post-op RT non-metastatic site. Next, please. So, in Turkish Federation trial, this trial favors the use of locoregional radiation, but the positive trial, it favors the systemic therapy. Next slide, please. So when we closely evaluate at these two papers, then we find that in Turkish trial, that is MF0701 trial, they have included the maximum number of hormone receptor positive tumors. HER2 triple negative are only 7% and bone only mets is 51%. So they have shown the survival advantage, but in EA210 might be they have not chosen the better biological favorable tumors. Next slide, please. So when we do the subset analysis in MF0701, which favors the treatment of locoregional therapy, we found that ER-positive tumor had better survival. If the age is less than 55 years, better survival. Bone-only mets and single bone-only mets, they have better advantage. Next slide, please. So even EA210 trial, 2108 trial, they have evaluated their overall survival by tumor subtype. For 20 women with TNBC, the survival was worse in the early local therapy arm. And for 47 women with oligometastasis, there is no difference in survival by the arm. Next slide, please. But the 4 trials, Tata Memorial, ECOG 2108, and an MF0701, they all three, they have shown there is a local control advantage. But positive trial, they have local control similar and it has low accrual and so many biases are in there. So basic point is the local control advantages is found in the both of the 3 trials. In spite the Tata Memorial and ECOG, there is no S advantage, but still the local control advantage still persists. Next, please. And the quality of life data from the positive and E2108, both of these papers, there is no quality of advantage in both of these. Next, please. So we discussed all the randomized trial. Now we are discussing the non-randomized trial. Next, please. So the first is TBCR data, where they have taken de novo stage 4 patients, treatment by physician and patient choice. They have included 112 patients, 46% bone-only mets, and 57% have single organ mets. And the first-line therapy they have given either in the form of endocrine only in 46% and trastuzumab in 25%. And if responders either in CR, PR or stable disease, they underwent elective surgery or no surgery. So non-responders have 13 months of median survival and 24% of 30 months survival. Responders without surgery, 65 months of median survival and 76%, 90 months survival. And the responders who underwent surgery, that is 39 patients, the 71 months median survival and 77% is the 30 months survival. Next, please. So second is the BOMET trial, that is bone-only disease MF1401 trial. This is a multi-center prospective registry study. They have included the de novo stage 4, but bone-only metastasis. They divided their group in 2 arms, one in systemic arm and one in locoregional treatment arm. In locoregional treatment arm, they have further divided into 2 arms, systemic therapy before the locoregional LRT or systemic therapy after LRT. And only the 6% of the patient, they have confirmed the bone mets by biopsy. Rest of them is confirmed by PET CT and bone scan. And the systemic choice is on physician's choice. So they have taken a solitary bone mets. In both cases, there is no significant difference in hormone receptor or HER2 status or histology at 34 months. But next slide, please.
Dr. Rashmi, can you sum up in a minute?
Sir, 1 minute. I will take 1 or 2 minutes. So MF1401 result, it shows that the locoregional therapy is better as compared to standard therapy. And when the systemic therapy is given before the locoregional therapy, it has added advantage. Next slide, please. So they all have shown that the favorable results. Next, please. Next, please. So next, please. So putting it all together, if we conclude the available level 1 data provide little justification at present for a physician recommendation from primary site locoregional therapy as a means of extending survival. Although the local control is improved by the use of primary site LRT, so far this has not translated into improved quality of life. So the primary site LRT can be considered if the primary tumor is progressing, but the distant disease is well controlled on systemic therapy. So this JCOG 1017 trial results, it is expected to come in the next years. And oligometastatic or bone-only disease may present distinct subtypes, like in BOMET study, where locoregional control influences survival, but this remains to be proven. Thank you. Thank you so much, sir.
Thank you, Dr. Rashmi, for presenting a controversial topic in a very detailed manner. Just quote, there are two meta-analyses. One came in 2020 and other one came in 2022. The 20 meta-analysis has shown that local regional treatment improves the overall survival, whereas Cochrane meta-analysis came this year only, indicated that local regional control is improved, but there is no change in overall survival. In my practice, I consider local regional treatment only when systemic disease is controlled and there is residual primary.
Yes,
I
sir.
thank the organizer for the opportunity and hand over to Dr. Tabassum.
Thank you, sir. Without wasting much time, now I would like to invite the faculty for the most exciting part of this session, which is the panel discussion. And the topic is nuances of local regional therapy and their impact on survivorship. So we have one of the most versatile faculty as a moderator for this session, who needs no introduction, Dr. Anushil Munshi, who is the HOD and consultant radiation oncologist at Manipal Hospital, New Delhi. And the esteemed panelist for this session is Dr. Pritanjali Singh, who is the additional professor and HOD at AIMS Hospital, Patna. Dr. Farhan, who is a consultant radiation oncologist at Apollo Hospital, Calcutta. Dr. Mukti Mukherjee, also a radiation oncologist at Apollo Multi-Speciality Hospital, Calcutta. Dr. Satyam Taneja, who is director at Department of Surgical Oncology, Max Hospital, Delhi. I'm not sure if Dr. Abhishek has joined. He is medical oncologist from Yashoda Super Speciality Hospital, Ghaziabad. Dr. Aditi Agarwal, who is senior consultant at Paras Hospital, Gurgaon, and Dr. Supriya Malik, who is additional professor in the Department of Radiation Oncology, National Cancer Institute, AIMS, New Delhi. Over to you, Dr. Anushil Munshi.
Thank you, Tabassum, and I hope my slides are visible and I'm audible.
Yes, sir. You are there, sir.
Okay, so without wasting much time, and requesting all panelists to kindly be very crisp in their comments and remarks. We have around 25 to 30 minutes and we'll be addressing 3 or 4 important issues related to breast cancer, especially in the context of the Centenary Breast Cancer Symposium. So the issue number 1, which I thought is of seminal importance and came up in the discussion today also and before the conference as well, is that can radiotherapy replace node biopsy? So can I request the radiation oncologist, Dr. Pritanjali, to please address this?
So, very good morning, good afternoon, everybody. I think that this question is very pertinent, and yes, it can address the radiotherapy can replace axillary lymph node dissection after positive sentinel lymph node biopsy. I do agree with this because there are.
Okay, thank you so much. So, Tanveer, can you please tell us which patients do you consider suitable for these strategies?
Sir, still to start with, I think axillary lymph node dissection is the standard, and we are trying to replace it. So it has to be done in a very cautious manner. So I'll be specific for T1 and T2 breast cancer patients with no palpable axillary lymphadenopathy. Only these patients.
So clinically node negative, mostly 1 to 2 positive sentinel lymph nodes, and most of these trials had patients with breast conservation. Do all the panelists agree with these criteria for these strategies, or is there any difference of opinion?
I would agree, sir.
Dr. Anushil.
Yes, yes.
Dr. Satyam Desai, being the only surgeon in the panel.
You have the first right to talk. Yes.
Yeah, that's what I was just saying. So the topic itself is very debatable, as you have started with. And there is no doubt about it, as Dr. Tanveer has just said, the standard of care has to be an axillary dissection in positive lymph nodes. And why we are actually discussing this is because of the comorbidities associated with the surgery and radiation, which are combined in the post-operative period. So,
can you please comment on how robust is the evidence? Very important point.
I would not agree with it.
So how robust is the evidence for or against this? So you mean to say that the Amaros studies and the Otasaur studies that are there, you have a difference of opinion with these studies, and may I know the reason why you have the difference of opinion?
I fully agree with you. Both the studies, the Amaros and Otasaur, I was just hearing earlier talks. Also, someone had presented it in detail, both the studies. The reason is these studies have been done when we were not doing surgical skills to the tune what we are able to do today. If you would have seen yesterday's video presentation in which we are doing, every center is doing, we are doing lymphatic preserving, full axillary lymph node dissection and reverse lymphatic mapping. With all this, the incidence of lymphedema in times to come will come down drastically, so it will not make much of a difference. That's my opinion on it.
So would we be right to comment that till the time such evidence emerges out in a context of preferably a randomized trial, till that time we are entitled to hold on to this randomized evidence?
Sure, I agree to you.
Thank you so much. So as we know, the data from the Amaros and the Otasaur study has kind of convincingly told us that we could replace, and in some ways we could also reduce the lymphedema rates. So, but definitely they have said that axillary radiation could be an alternative in such situations. But then I have yes.
Sir, this is Supriya, sir. Sir, just I want to make a point that ACOSOM Z11 clearly says that if there is 1 to 2 node positive, then there is no need to go for further ALND.
Yes, we'll come to that also. We'll come to that. Yes, definitely. That's a very important point. We'll come to that. So before that, I have a few questions for my own community, radiation oncologists. So we often say that, okay, we can combine and we can substitute surgery with radiation for axilla. So now my question to the radiation oncologists, and we have very eminent radiation oncologists in our panel today. So the practical question is that in your practice, have you done comprehensive axillary treatment for such patients? And if you have done, you must have combined level 1, 2, 3 and SCF as the target volume. And once you have combined all these as the target volume, including the breast area, did you face any planning issues? Do you have any class solutions for beam placements? And what would be your typical dose and fractionation for such patients? So can I ask Dr. Aditi or Dr. Mukti to comment on these very important issues, which are not often discussed in conferences, but will land up into issues when we are sitting at the planning station and contouring and then finally seeing the plans?
Yes, sir. Actually, this becomes very, very important, though I have not treated axilla and SCF for such a situation. But yes, whenever we treat axilla and SCF along with breast, lung and heart doses for left-sided disease would be very, very important. So planning becomes really challenging as compared to when we don't include the axilla and we just have to treat the SCF. As for the class solution for beam placement, most of the times we try to use tangential beams, but that also the technique would vary from in forward planning IMRT to inverse planning IMRT to VMAT, and left-sided breast tumors, definitely DIBH helps. So there is no one class solution for these tumors because the anatomy would also vary. The extent to which a patient can do DIBH would also vary.
So thank you, Dr. Aditi, and any other radiation oncologists who can add to what
sir. The problem that I see is the dose to the femoral, the humeral head, and that may be the cause of shoulder restriction in future. If we see the data from Amaros also, shoulder restriction is significantly high for the patients who receive radiation, and that is a typical problem that we face. Of course, it increases the lung dose to significant extent also.
Dr. Tanveer, did you have the opportunity to treat such cases? I think his signal is poor. So Dr. Supriya or Dr. Farhan?
Sir, I just told about the dose to the shoulder joint. I was talking about the shoulder joint dose. That is typically increased, and brachial plexus.
Okay, fine. So let me add to this. I did have the opportunity to treat some cases. I'm not saying a large number, but some cases. And as you can see, this dotted area, which gets added to the breast volume once you start treating axilla, and then you have to combine it with level 1, 2, 3, and the level, the supraclavicular area, and it becomes actually one large volume, treating which poses certainly some challenges. So it's very easy to say that we can substitute radiation for axillary treatment, but practically it does pose some challenges to us as well. And in fact, you can see these low dose areas also climbing up. And not only that, if you see the MROS update, the 10-year update, and it was presented in SABCS in 2018, and maybe not many people have focused on this, but there were certainly more second primaries observed after axillary RTs. The number were not huge as compared to axillary lymph node dissection, including contralateral breast cancers, 21 versus 11. 11 with axillary lymph node dissection and 21 with axillary RT. So I think we also need to sound a cautionary note regarding the rest of the doses that possibly climb up once we treat these larger volumes. Do my panelists agree, or they strongly disagree?
I definitely agree, sir. I want to add another point, that is in the axillary fold, the skin toxicity, and mostly in our hot and humid country, the skin toxicity is definitely an issue. So for that skin reaction, we have to stop radiation for 1 or 2 weeks. So that is another problem we faced.
Now, besides, there is another list of questions that remains unanswered with all these trials. For example, questions like, do all the patients, and this was being discussed, I think this question was raised up by one of the panelists. So in light of the evidence from Z11 and MROS, if we combine the evidence and the light that we are getting from these two trials, do all the patients need axillary radiation to all the 3 levels and the medial supraclavicular fields as well? Or can we de-escalate radiation? Would some patients benefit from additional internal memory nodal radiation as well? So these are the questions which really don't have any answers as of now. Any comments from the panel?
Sir, there was a small percentage of patients who did not receive RT even in this trial, around 20% of those patients. So what they have discussed is that maybe the systemic therapy is effective enough to take care of the unaddressed nodes. We don't really know what is acting.
Dr. Abhishek is with us. The medical oncologist, the lone medical oncologist, oh, he's not joined. Okay, fine. So I think we move to the next issue. In the same area, the axilla, how do you address regional radiation after neoadjuvant chemotherapy? And we begin with our dear surgical colleague only, Dr. Satyam. So may I ask Dr. Satyam, because what we do as a radiation oncologist is heavily dependent on what you do as surgical oncologists and what kind of surgery has been done, including addressing the axilla. So our portals and our treatment is heavily dependent on what the surgical colleagues have done. So can you please comment on this broad issue, and then we go to the specifics?
Thank you very much, Dr. Anushil. Regarding LABC and neoadjuvant chemotherapy, basically we have to divide LABC based on a lymph node mets or the primary disease. If it is a T3 disease, we are giving NACT, or we are giving NACT to do a breast conservation surgery. So in our practice and most of the surgical oncology practice, I'll say if we have a post NACT positive axilla, we are not doing sentinel nodes for those patients. We are doing full axillary dissections. But in certain subset of patients, when we are giving NACT for locally advanced by the virtue of primary disease, in those patients, we still give them option, or we are still more bent upon doing a sentinel lymph node after NACT also.
Okay, so can I turn to my radiation oncology colleagues? Dr. Tanveer is there?
Yes, sir, I'm there, sir.
So Tanveer, can you please take these very, very crucial questions? What do you do with initially node negative axilla, initially node positive axilla, and after chemo has been given in these two situations, what is your approach to axillary or regional RT?
So I will divide the patients whether the patient is patient is node negative, but if the patient is T2 or T3 and axillary negative, the patient has undergone a neoadjuvant chemo, then it becomes challenging. But still, in that case, if patient has taken neoadjuvant chemotherapy, I'll still go and give the radiation. That's one thing. And if the nodes are positive,
no, just a minute. Initially, a node negative axilla T1, T2 patient who has received neoadjuvant chemotherapy. Post chemo,
post chemo T1, T2.
Would you in any way address the axilla?
No,
after, say, for example, Sentinel has been done, Sentinel is negative, and do you want to address the axilla?
No, sir. So T1, T2 and node negative.
So we are all on the same page. Now come to the next issue. Initially, node positive axilla.
In node positive axilla.
Now remains node positive or becomes negative. So what do you do in these two situations?
Sir, even if it becomes positive, no doubt you'll go and address the axilla. But even if it becomes negative also, and if it was initially node positive, and specifically if it was N2 and N3, then definitely no doubt I'll again give radiation to the axilla. So I'll address the axilla.
And of course, this approach would be dependent on what the surgeons have done. So again, coming to you, Dr. Satyam, what do you think is the standard of care for sentinel lymph node after chemo has been given? Which cases do you take for sentinel lymph node after neoadjuvant chemotherapy?
As I just mentioned, we are only doing sentinel lymph node after neoadjuvant chemotherapy only in those patients in which we had a proven FNAC negative axilla, ultrasound guided FNAC negative axilla.
Are you being overcautious? Because there is a reasonable evidence, for example, from the Cyanotype trial or Toxicity trial of N1 nodes post chemotherapy, and they have demonstrated a false negativity rate of as low as 6 to 7%, provided you are doing at least 3 lymph node dissection, provided you are doing dual kind of mapping, and provided you are kind of doing clipping and chasing that node. So do you think those approaches are not, as of now, a standard of care or not acceptable in our country?
So there are multiple trials going on that you have just mentioned, the Sentinel, the SN-FNAC trial, there is a Z1071 trial, post NACT, there is a clip placement trial, the RIAS trial. So all these are too early to get it into our Indian practice. I'll be that frank with you. For surgeons to be able to change our surgical practice, we need real robust data so that we can change our practice, because it transforms into long-term outcomes for the patients. So I personally don't feel that with a positive sentinel node pre-NACT, I'll be subjecting them for a sentinel node post-NACT.
I think two very, very crucial trials that we have to look forward to: NSIBP 51 Alliance A011202. One which randomizes women with breast cancer who undergo lumpectomy or mastectomy and have post-NAC YPN0 randomized to RNI versus no RNI. And Alliance, again, a very interesting trial. Patients who remain YPN positive on sentinel node after neoadjuvant chemotherapy randomized to axillary lymph node dissection and RNI versus RNI alone. Very, very important trials. And of course, there is one more trial, which is the post-NOC trial, because most of these patients otherwise have gone into the conservation trials and this thing, but post-NOC addresses even the post-mastectomy scenarios, I think, and very, very crucial trials, the evidence we are looking forward to. I now change gears again, and now again, a very, very important issue which has been haunting radiation oncologists for a long time, the cardiac issues related to breast radiotherapy. So coming again to my dear radiation oncologist colleagues, Dr. Supriya or Dr. Aditi, can you take this question? What are the risk factors, especially in light of the evidence that is coming? What do you think are the risk factors for radiation-induced heart disease?
For radiation-induced heart disease, sir, if there is a pre-existing heart disease, if the patient is diabetic, hypertensive, is having dyslipidemias, They're all risk factors, has received some concomitant, some chemotherapy, systemic chemotherapy, which is cardiotoxic, anthracyclines, trastuzumab. These are all the risk factors. And definitely the technique with which we give radiation does make a difference.
Sure.
To add on, Dr. Anish, I just may add on that the total dose to the heart, the dose, basically volume of the heart that is involved, of the coronary vessels,
Of course.
left side treatment.
Any comments on the pathways study, heart study? Pathways heart study. So pathways heart study came up in the symposium, and it again reinforced the view that other factors such as being overweight are also risk factors for radiation-induced heart disease. Do any pharmacological agents used along with radiation therapy help as cardioprotectives, especially in the view of recent evidence? Any comments on that?
So there are certain drugs that can be tried. I think there are some retrospective data for using AC inhibitors or ARBs or some beta blockers also. There are earlier some retrospective data, some meta-analysis that says that there may be some cardioprotective role. Recently, there was a trial, I think JAMA published the SAFE trial that said if you use both either enalapril plus a beta blocker, that reduces the cardiac events significantly. So these things, but however, there are certain other efforts are being tried, certain other drugs, just statins, certain stress-induced agents. These are all being used. So as of now, I feel the SAFE is the only randomized phase 3 trial that gives some hope of cardioprotective role of these drugs. Others are evolving slowly.
So the evidence from the SAFE trial actually says that maybe these agents help in protecting the heart from chemotherapeutic agents. As far as radiation, actually not much was being achieved by use of these agents along with the radiation. So no benefit actually was happening in patients, especially those who were most important, the left-sided breast radiotherapy.
And so also
patients.
the question is how long
not much benefit was. So long will be another question, but whatever so far is not showing that some benefit is happening, but the length of treatment could also be considered. Okay, so radiation oncologists again. Should we be, as radiation oncologists, we have often been kind of very fond of the mean heart dose. As a radiation oncologist, do you think that we need to do much more beyond the mean heart dose, or do you think this parameter is good enough? Dr. Pritanjali, Dr. Tanveer?
Sir, okay, ma'am, please, you can continue, ma'am.
So as far as the mean heart dose is concerned, we were considering that initially, but now there have been many studies which have shown that the left anterior descending coronary vessel, the dose to that also is important to know the atherosclerotic changes and the risk induced to the heart diseases. So we should consider this also as one of the new parameters while evaluating the.
Tanveer, you wanted to add something?
So we should gradually, mean heart dose is not only the one. Hello, so am I audible, sir?
We can hear you. Yes.
Hello. Yeah, am I? Yeah. So mean heart dose is not only the one criteria. We should start even thinking about that. It's not only the mean heart dose, but even the what is the mean dose to the left ventricle? What is the V5 to the left ventricle? Then like the way the lungs, the pneumonitis is involved, the similar way, like what is the V23 for the left ventricle? So other parameters has to be taken into account, plus also the left anterior descending artery, what is the mean dose? Like left anterior descending artery is basically a serial organ. So even proximal, middle, distal. So all those has to be taken into account. So we should gradually start moving from the just the mean heart dose, because mean heart dose is just a representation of the mean, but where is the maximum dose coming, which particular point, all those can cause electrophysiological defect. So that has to be kept in mind.
Sure. And as you can see, there is critical evidence telling that the distribution of stenosis after radiation very well correlates with the hotspots that we have created during radiation. And at the bottom, you can see the evidence telling us that women who are receiving more than 5 gray mid-LED mean dose, their odds, their risk for the later coronary intervention significantly increases, especially if they are receiving more than 20 gray, dramatically increases many-fold. So we need to be very sure about other areas as well. Of course, there are issues such as knowing where the vessels are, contouring the vessels, and should we be doing an additional imaging and then fusing it? These are the challenges as radiation oncologists. We ourselves proposed a coronary strip technique. I don't have the details to go into this, but we need to find out our own tools to kind of designate in some way where the coronary vasculature is, so that we can separately delineate it as a separate area and give it to our planning systems. And it's not only the coronaries, it's also that if you go into detail, each substructure of the heart, whether it's the left atrial wall or the pericardium, the right ventricle, left ventricle, SVC area, and all those, and the base of the heart, everyone has its own dose constraints, which we should try to respect. So what are the critical measures that can be employed for cardiac safe radiotherapy? Dr. Mukti would like to comment. Dr. Mukti is there. Dr. Supriya, Dr. Pritanjali.
So the critical measures that can be employed is, of course, cardiac shielding is there, then the beam placements that we have to do. Then we have to contour all the targets, OARs. As you said, the substructure contouring of the heart is very, very important. And as of now, we have heard about the different agents that may help for cardioprotection of the heart. Then we can use those things as well. And of course, DIBH is also one important aspect which we would like to consider when we are treating, especially the left side of the heart.
Thank you so much. So this question is addressed to actually all my panelists, including surgical, medical, radiation. Do you treat the primary with surgery or radiation in patients with metastatic breast cancer? Dr. Satyam, what is your take on this very, very crucial question?
There were discussion on this just before our panel discussion by Dr. Rashmi also. So there are only certain subset of patients with the oligomet, with a single bony met. In such kind of patients, you may consider primary treatment of the breast before starting any adjuvant treatment.
So what approach do you feel is preferable? First systemic therapy followed by local treatment, or local treatment followed by systemic therapy?
It all depends upon the general condition of the patient, the ASA grade of the patient, and how we are thinking that because of the surgery, how much the systemic treatment will be getting delayed. If you are thinking that you will be able to start systemic treatment, maybe within 15 to 20 days, that's what we normally say, we wait for 3 weeks. There are certain subsets we can start at 15 days also. In those subset of the patients, I would think of doing the primary first and then subjecting for the systemic therapy. Otherwise, when there is comorbidities and you are expecting that the post-operative course may not be that smooth, you may subject for systemic therapy first and then considering for.
Dr. Aditi, do you have a difference of opinion?
Then I would always want to give systemic therapy first, because whatever said and done, it is metastatic disease. And only if there is some bone met pain, I would like to give local therapy at that side first and then proceed with systemic therapy.
It will also depend upon the molecular markers of the patient, based on which you may like to take a call. Suppose it is triple negative breast cancer with a single bony met, then you would like to subject for, I would personally like to subject for a systemic therapy, not to think of the primary removal in the upfront case. So there are very less subset of those patients in whom you will be thinking of removing the breast or giving the treatment to the primary before starting systemic therapy?
So we already have seen this evidence, the Tata Memorial evidence, the ECOG Endocrine evidence, which has recently come up. And we also know that trials have adopted different strategies for their patients. But the broad outcome that is coming is that, so again, you had the Turkish trial evidence, the EBCSG trial evidence. We have discussed all these things. The big question is that our outcomes, and this keeps on coming again and again, are outcomes for local treatment better if we select bone-only metastatic patients? Now, this is a very, very important question, because even the trials, some of the trials have pointed out that in bone-only metastatic patients, they had better outcome for doing local treatment. So what is the take of the panelists on this, Dr. Pritanjali or Dr. Tanveer? Hello, Dr. Aditi.
Sir, it's all about selecting our patients as we move from polymetastatic to oligometastatic, and amongst oligometastatic also we are trying to pick up the more favorable group. So bone mets patients are the more favorable ones. And as data is also showing us, the bone mets patients are doing better. So more aggressive therapy is likely to have more benefit in these patients.
Okay. And some corroborative evidence has come from the MF14 results also, which was focusing on bone metastasis only patients. But have there been issues in these trials? Have these trials been loaded with flaws? Dr. Satyam, you want to say something, or my radiation oncologist colleague want to say something? What have been the big issues which you feel in these trials?
To be very frank, I'll not be able to enumerate the fallacies in any of these trials, but for the personal point of view, it is only the bone mets only patients which we are subjecting or thinking of local treatment.
So there was near absent use of Herceptin in the TMH trial. There were higher visceral or overall metastasis in the TMH trial compared to the Turkish trial. There was upfront randomization, for example, done in the Turkish trial. Non-uniform policy regarding local treatment of metastatic disease in nearly all the trials. So what is happening is that we are remembering, for example, in some trials, the local treatment, we are focusing on that, but what is happening to metastatic disease? What is happening to the local treatment of metastatic disease is sometimes being overlooked in these trials. Yes?
Just wanted to make a point, sir. Sir, these all are heterogeneous tumors. Breast cancer, as we know, there are so many heterogeneity. So all these trials are trying to bring all the heterogeneity together. And so if there is a small benefit, that will not be appreciable. And of course, as you highlighted, the therapeutic options varied very widely. And most of the times, just like Herceptin was not used in the Tata trials, the recent developed drugs, those were not also part of the therapy. So there is a gross heterogeneity in the design also and the execution also.
That's what I'm trying to point. So I agree, there has been a non-uniform policy, and that is why we are still at perhaps the crossroads as to what's to be done in such situations. Of course, JCOG 1017 trials are expected next year, so maybe some more light will be shed. So till that time, I present the kind of a consensus. If a panelist has a difference of opinion, they can readily point out. So those patients could be considered for local surgery or RT in metastatic disease who have good response to first-line systemic therapies, good performance status, oligometastatic disease, which again we need to define, and bone-only involvement. So perhaps, and no visceral involvement. So perhaps this small category of patients could be considered for local surgery or RT in the context of metastatic disease.
I agree to you, Dr. Anushil. There is no doubt about this.
So everyone agrees on this consensus? Great. And the other thing that, again, I'm bringing this, the SABR COMET trial, because these trials addressed a separate issue. They were kind of focusing on the metastatic disease now. Whereas the previous group of trials were focusing on the primary local treatment. So if we combine these two, perhaps we'll recognize the need of trials addressing, for example, the issue in a randomized setting of systemic therapy alone versus systemic therapy plus primary addressal plus limited metastatic site, whatever is there, aggressive management of all that. So aggressive management of local plus limited metastatic site plus systemic therapy versus systemic therapy alone. Perhaps maybe trials such as these are needed to solve this conundrum. And now final 1 or 2 minutes only, we are left with very little time. Does anyone in the panelists feel that is breast radiation based on molecular markers ready for use in the clinic? Aditi?
Sir, as of now, we are still relying on the T stage, the nodal status. We do not take our decisions based just on the basis of.
So there are a lot of trials, evidence coming on, but still, I don't think we. Any other panelist has any opinion? A difference of opinion other than this? So why are radiation oncologists still unconvinced? Pritanjali, you want to say something?
So there's not much data to suggest that if we can, just look into the molecular profiling as we do in for the sake of chemotherapy and everything. So we need more robust data coming in.
So one is lack of randomized evidence. Then most of these trials which have been done, they have adopted a all or none approach, which perhaps is either you give radiation or don't give radiation. But there could be situations where a low dose or a higher dose of radiation is required, or the volume of the area that you need to treat needs to be tailored, and most of the trials don't address these issues at all. And of course, there are various dilemmas, for example, that keep on coming out in this very important trial in which 21 gene recurrence score was assayed in JNCI in 2017, often quoted and repeatedly quoted. So while in the overall group analysis, the recurrence score correlated with the loco-regional recurrence, but then if you separated them out, 1 to 3 nodes and more than equal to 4 positive nodes, paradoxically, the recurrence score was holding well for more than equal to 4 positive nodes rather than the low risk group of 1 to 3 positive nodes, which is quite paradoxical in a way. We expect evidence to come first for the low risk group of breast cancer patients to guide us what we have to do in that. High risk patient, I don't think anyone would be taking that much risk of not giving radiation to a patient with 4 or more positive nodes. But then again, this is a kind of a counterintuitive result that has come up in this study. So what is the way forward? We need to look forward to these trials. Again, most of these trials have focused on a low risk. If you see, they are PT1 and zeros. Most of these trials are PT1 and 0 patients, low grade patients, a low risk population, which is being randomized. So still we are trying to have a hold on what's happening to the low risk population. And once we have evidence from this, then only we can consider a higher risk population. So as radiation oncologists, I feel, and this is the way I could sum it up, the need of the hour is this whole group of patients which is there on the left side, which we either treat by radiation, or as of now, we either treat them with radiation or we don't treat them. That's the only decision we make. Either I'm giving him radiation or I'm not giving her radiation. So by means of molecular testing, if we could split them into patients who require more radiation dose, standard radiation dose, less radiation dose, or no radiation at all, and also preferably tell us about what is the fractionation that I can use, what is the need for regional radiation, and how much the treatment volume should be. And that, if molecular analysis tell us, I think that would be really, really beneficial to all of us. With those words, thank you all for being in the panel, and thank you organizers for organizing such a wonderful scientific event. Thank you.
Thank you, sir.
Hello, Gagan sir.
Yeah, Palak.
Yes, sir. So you can conclude the session and.
Okay. Well, enough has been said in chats and the online chat that this is one of the most productive session yet. We have learned a lot, and it was very varied, thanks to the agenda that me, Dr. Tabassum, and Dr. Reema Pathak created. I hope everybody enjoyed it. I thank Dr. Sareen, Dr. Meenu Walia, and everyone for joining here. Have a great rest of the day. Have a great weekend. Dr. Reema, you'd like to say something? Dr. Tabassum?
No, I think everyone participated very well, and the interaction on the chat groups was also excellent. So I think it was a great success in every way. I think every one of us enjoyed, and we were all engaged in the discussions throughout the meeting. Thank you so much for the opportunity, and hope to see all of you all again on some forum again. Thank you.
Yeah, thank you, Dr. Gagan, Reema, and all three of us have got it on the topics. I was a little apprehensive. I mean, for the first time, we are discussing such a varied variety of topics, but I would say all the faculty have done their job really very well, and it made the program a big success. Thank you, everyone.
Thank you, ma'am. Thank you, sir. Thank you all. Support team, can we close the meeting?